hias langit biru, oh Indonesiaku. Tunjukkan dirimu kepada dunia dan torehkan warnamu di dalam dada.
Aku ingin kepada dunia ini menunaikan kewajiban putra bangsa yang mengemban cita hidup dalam kesatuan.
The Milky Way upon the heaven is thanking just for you. And Mr. Moon, he came by to say good night to you. I'll sing for you, I'll sing for Mother, we're praying for the world. And for the people everywhere, when I show them all we can. Oh my sleeping child, the world's so wild, but you breathe you home. Paradise, that's one reason why I'll cover you, sleeping child. All the people around the world, they had a mind like yours. We have no fighting and no wars. There'll be lasting peace on earth. If all the king and all the leaders can't see you heard this way, they will hold the earth in their arms. They will learn to watch you play. Oh my sleeping child, the world's so wild, but you
Inilah Indonesia, keanekaragaman budaya dari berbagai daerah berkumpul menjadi satu kesatuan menciptakan generasi muda yang aktif dalam dunia kesehatan. Karena jiwa yang sehat akan menciptakan bangsa yang kuat. Institut Ilmu Kesehatan Strada Indonesia, kampus kesehatan yang berada di Kota Kediri, memanggil kaum muda Nusantara untuk sadar akan ilmu kesehatan. Terakreditasi B, memiliki berbagai program unggulan, menunjang branding internasional dengan pemberdayaan dosen yang profesional di bidang kesehatan. Maka terciptalah mahasiswa yang kompeten. Branding 4G memaknai kampus dengan mendukung program kampus Merdeka Belajar, Good Competen, Good English, Good Personality and Mentality, Good Placement of Preparation akan membawa lulusan kampus kesehatan Strada mampu bersaing di tingkat internasional. Memiliki 12 prodi dengan jenjang vokasi, sarjana, profesi, dan pasca sarjana dibentuk menjadi 3 fakultas dengan atmosfer belajar yang nyaman, pelayanan yang ramah, serta lingkungan yang asri mendukung berlangsungnya perkuliahan yang kondusif. Tak lupa dengan modul online, efektivitas pembelajaran pun tercipta. Inilah kampus mahasiswa seluruh Nusantara menjadi satu kesatuan. IIK Strada Indonesia mencetak generasi milenial berbasis kesehatan. Brighter Future, English and Digitalisasi, Kampus Strada Indonesia.
while Miss Biba come to stage, I wanna introduce her. That Miss Biba is the steering committee for the 4th Strada International Conference on Health. So for this agreement, I will give to her. This is the commitment to next Strada International Conference. Okay, Ms. Biba, maybe you wanna say something, a short what the preparation for the 4th International Conference of Strada, maybe a short statement. 10, it's yours.
Thank you to Mr. Sodik. Assalamualaikum warahmatullahi wabarakatuh. Good morning all the participants. Thank you to Mr. Sodik for giving me as the Dean of Nursing and Midwifery Faculty. I accept about the steering committee for the 4th International Conference Strada. So the Strada International Conference on Health, the 4th can be held in 2020. So thank you for the Mr. Sadik, and I give it back to Mr. Sadik. Wassalamualaikum warahmatullahi wabarakatuh.
You can back to your stage. Okay, ladies and gentlemen, the last I say for me once again, enjoy your journey, enjoy your new network, your new information of knowledge during 2 days, this day and tomorrow. So the last for me, thank you very much to all participants. Assalamualaikum warahmatullahi wabarakatuh.
Thank you to Mr. Ali Sadiq, Master of Art, for the speech.
Ladies and gentlemen, and all the participants, for the next agenda, that is opening remark and speech from respectable Dr. Sentot Imam Suprapto MM, as Director of Institute of Health Science Strada Indonesia. The time is available.
Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah rabbil alamin. Asyhadu an la ilaha illallah wa asyhadu anna Muhammadar Rasulullah. Allahumma shalli ala Muhammad wa ala ali Muhammad. La haula wa la quwata illa billahil aliyyil azim. Honorable Professor Sandip Podar from Lincoln University. Honorable Associate Professor Dr. Naremon Aminekul from Mahidol University. Honorable Dr. Tanko Titus from Nursing Mina, Nigeria. Honorable Nita Madhav from San Francisco, USA. Honorable Zainal Abidin, Magister Kesehatan from Bhakti Husada Mulia, Madiun. Good morning and how are you? Please, it's my great pleasure to welcome you to the SICH Strada International Conference in Kediri. We are very grateful and of Bhakti Mulia Husada Madiun College for tremendous support as co-hosts. We would like to thank our speakers and participation, whom I hope will share knowledge, insights, and experience during the conference. Ladies and gentlemen, COVID-19 as a pandemic has shocking global effect and weakens our system in every country. Mortality, morbidity, hospitalization is enormously challenging, and the global discussion, ideas and innovation are critically needed to evolve the current response strategic in COVID-19 pandemic. It's wonderful thing about Strada International Conference on Health is a combination of our member international perspective to think, to discuss the problem pandemic COVID-19. The conference theme is living with COVID-19 endemic opportunities, reach, preparedness, and adaptation. We will discuss strategies, innovation for COVID-19 endemic preparedness and recovery conference. Before coming to close these remarks, I would also like to remind you, and especially our moderator, and strictly stick to our schedules and not let any session overrun. Ladies and gentlemen, I sincerely hope you will enjoy the 2 days of discussion, debate, and networking. Thank you with your participation. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much for respectable speaker. Ladies and gentlemen, the next agenda is the opening celebration by giving the call to the Honorable Director Strada Indonesia, Mr. Dr. Sempat Imam Suprapto, Magister Management, accompanied by the head of the committee, third Strada International Conference, Mr. Ali Sadiq, Master of Art. Time and place are yours. Okay, ladies and gentlemen, the session is going to be a taking picture for the IT team. Please. Okay, for all of the participants, the next agenda is take a picture. Please turn on your camera and the team IT will take the picture. First, slide. I will count 1, 2, 3. Okay. Okay, next slide. Thank you and enjoy this agenda.
Inilah Indonesia, keanekaragaman budaya dari berbagai daerah berkumpul menjadi satu kesatuan menciptakan generasi muda yang aktif dalam dunia kesehatan. Karena jiwa yang sehat akan menciptakan bangsa yang kuat. Institut Ilmu Kesehatan Strada Indonesia, kampus kesehatan yang berada di Kota Kediri, memanggil kaum muda Nusantara untuk sadar akan ilmu kesehatan. Terakreditasi B, memiliki berbagai program unggulan, menunjang branding internasional, dengan pemberdayaan dosen yang profesional di bidang kesehatan. Maka terciptalah mahasiswa yang kompeten. Branding 4G memaknai kampus dengan mendukung program kampus Merdeka Belajar, Good Competen, Good English, Good Personality and Mentality, Good Placement of Preparation akan membawa lulusan kampus kesehatan Strada mampu bersaing di tingkat internasional. Memiliki 12 prodi dengan jenjang vokasi, sarjana, profesi, dan pasca sarjana, dibentuk menjadi 3 fakultas dengan atmosfer belajar yang nyaman, pelayanan yang ramah, serta lingkungan yang asri mendukung berlangsungnya perkuliahan yang kondusif. Tak lupa dengan modul online, efektivitas pembelajaran pun tercipta. Inilah kampus mahasiswa seluruh Nusantara menjadi satu kesatuan. IIK Strada Indonesia mencetak generasi milenial berbasis kesehatan. Brighter Future, English and Digitalisasi, Kampus Strada Indonesia. Inilah Indonesia.
Ladies and gentlemen, now this is what we are waiting for. The main agenda for today, panel discussion.
Ladies and gentlemen, in this first symposium, we will deliver topics presented by Associate Professor Dr. Narayman Amin, PhD PhD, Mahidol University, Thailand. This discussion will be led by Chairwoman Ms. Riza Yuliati SQM MRTH and Co-Chairwoman by Ms. Mika Feronesia Honora SQM MPH.
Hi everyone, can you hear me? Can you hear me? Okay. Okay. Can you hear me right? Yeah. Okay. Can you see my screen and as the full screen? Okay. 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 Associate Professor Dr. Narwemon Aumanikul. First, let me introduce myself. My name is Riza Yuliawati, SKMMIPH, as the chairman or as the moderator in the first session. So, before we go on your presentation, first of all, I will state about the rule for today's conference. So, for the participant, please join in this conference with the on-cam. So if it is possible, please always on your camera. And then the second, if there is any question for you, please write the question on the chat column, and then we will collect and read your question in the Q&A section. And then here for the question and answer is in the parallel scheme. So after the first and then the second speaker have their presentation, and then we will have 30 minutes question and answer after the second speaker have present their presentation. Okay, I think everything of my explanation is quite clear. Okay, so I will say in bahasa as well to make everybody understand about what I explain. Jadi untuk partisipan yang pertama mohon on cam gitu ya, mohon kameranya dinyalakan. Yang kedua nanti untuk pertanyaan adalah setelah pembicara kedua selesai mempresentasikan presentasinya gitu ya. Jadi sistemnya adalah paralel. Jadi nanti pembicara yang pertama presentasi dulu, yang kedua juga presentasi dulu. Kemudian setelah itu baru nanti ada paralel question and answer session. Oke, seperti itu. Dan untuk yang bertanya, nanti pertanyaan mohon maaf only in chat box. Jadi pertanyaan hanya bisa di kolom chat saja. Begitu ya. Oke, so I think without no more statement from me, I will welcome Associate Professor Dr. Narwemon Aumanikul from the Faculty of Public Health, Mahidol University, to present your material. Now the time is yours, Associate Professor. สวัสดีค่ะ อัสสลามุอะลัยกุม
Good morning, dear all professor and all participants. I'm Associate Professor Dr. Nanmontur Manikul from Mahidol University, which is the university ranked #1 in Thailand. I feel very honored and feel very proud to be here as a keynote speaker regarding the community participation and community management during COVID-19 in Thailand. My special thanks to go to Henry, our master student in International Program of Public Health. And he is a staff from Strada International who brought me the opportunity to be here today. Thank you a lot. Regarding to the COVID-19 in Thailand, first of all, I wish to share you guys that since there is the pandemic of COVID-19 in Thailand, the government set up the Center for COVID-19 Situation Administration, or abbreviation term is CCSA, as a Center for COVID Information and Management, where the information updated will be announced daily and broadcast every day to Thai citizens. And to bring you guys the overview of COVID-19 pandemic in Thailand, there were the first 2 cases COVID patients from Chinese tourists entered to Thailand in January 22nd, 2020. After that, the first higher wave where the COVID infected reached 1,000 was at March 26, 2020. And this was the first time our Thai Prime Minister announced an emergency decree before Thai New Year in April. Thai New Year will not be in January, it is in April. And after Thai New Year, there were many easing down about the lockdown restriction. Afterward, a lot of eased lockdown restriction afterward. So it's up here the second wave. So the second wave was happened during the end of 2020, December 18 to 20, from immigrant flesh market at suburb area of capital city, Bangkok, Thailand. And from this second wave, the active case finding in community was started. The yellow bar chart shows the number of active finding cases from community since then. The first announcement of the integrated control and the truly starting point of community participation for COVID-19 management is happened during this time, during this second wave. Okay, and after the second wave, the COVID alpha variants start in Thailand during April 2021, and that caused the third wave from nightclub cluster because a lot of easing of lockdown. That's the reason why. Later on, COVID Delta variants start 1 month later, Alpha variants during May 2021. In the left-hand side graph, show the prediction wave of new COVID-19 cases simulation based on Delta variants outbreak pattern in India. In that case, the spread in Thailand may have peaked And we pray that COVID lambda variants will not appear in Thailand, because if it appear in Thailand, that would be pose a major problem. So as we know that the pandemic affect many disruptions in every country around the world, Thailand now are move forward to the uncountable wave. It's called uncountable wave now, but the Thai government still try to convince the citizen that we are at the fourth wave, where the result of pandemic could cause psychic trauma. Citizen among citizens, I mean, it may cause psychic trauma to or mental illness among Thai citizens, together with the economic injury and burnout, especially among shortage public health personnel. They have a burnout problem a lot. And for the vaccination, because I want to show the overall of Thailand first and then community participation later. For vaccination, Thailand applied mixed and matched vaccine. I don't know whether or not in Indonesia and Malaysia or USA also apply this mixed and matched vaccine. Basically, we apply Sinovac and AstraZeneca, or AstraZeneca and Pfizer, or Sinovac and AstraZeneca. Recently, Thai government approved the mix and match of Sinovac and Pfizer. But right now we are looking forward to receive the Moderna, which is the choice where it's supposed to reach Thailand during the mid of November. For COVID-19 pandemic management in Thailand, we basically group the people into 3 groups, or we call 3 tiers. The infected people with PUI, you can see this one is the infected people with PUI, with confirmed with RT-PCR positive, represented by red color. The first tier is the people who close contact with infected people. We group them as the high risk, represented by orange color. And the second tier is the people who contact with the high risk people. We group them as a low risk group, represented by yellow color here. And the third tier is the people who contact with low risk people. We group them as no risk group, represented by green color. For tier number 1, number 2, number 3, which is not infected yet, we suggest them to apply the HTTA, or its abbreviation from distancing, mask wearing, hand washing, temperature checking, and COVID testing. And lastly, they would have Thai government application report that we have to check in everywhere that we go. So we suggest them to use the HTTA for those who are not infected yet. And for those with negative results of RT-PCR, either tier 1, 2, or 3, orange, yellow, or green group, especially high risk in yellow group. in yellow group or high risk group who close contact with the patient, we would assign them for 14 days quarantine. And we have 7 types of COVID-19 quarantine in Thailand. Depending on the criteria, for example, Thai citizens come back from other countries or foreigner come to Thailand, they must be in state quarantine. In state quarantine, the government will be sponsored. And those who want to quarantine in alternative state quarantine, they may have to pay by their own because they want the best service or better service than the government one. For another criteria would be assigned into local quarantine, alternative local quarantine, organizational quarantine, hospital quarantine, and alternative hospital quarantine. For those infected with COVID-19, which is confirmed ATK with RT-PCR, would be grouped also into 3 groups. This is the patient with COVID infected already. Okay. So we would group them into 3 groups regarding the symptom of COVID pattern. So the reason we group them as 3 groups of the color is because of for hospital bed supply management. The COVID green blue represent the patient who have only URI sign and symptom, but they can help themselves. They are not, they don't have any sickness appear much. For a COVID yellow group, they will represent the patient with abnormal chest X-ray, and the COVID red group represent the patient with oxygen sat or oxygen saturation at room air condition less than 69%. And they will have the chest X-ray with progression of filtration, as this would need at least the high flow nasal cannula to on respirator. They need high flow nasal cannula, or some may need to on respirator. So the red one is supposed to be the group that we have to give them the special care. So the critical ICU ward COVID would be provided for COVID red group with major symptoms. They would be assigned to admit in state-run hospital. The major treatment in Thailand we use, of course, favipiravir. And there are another alternative choice of waiting list medicine, including Thai herbs that provide by Thai government as the preventive medicine. So we basically use favipiravir and Thai herbs for prevention. But for another drug, it's on process that we import from US, and also we import some ingredient from China. And there is some trial in another university called Chulalongkorn University that they are in the trial version of the 3rd phase of COVID-19 vaccine of Thailand. So for COVID-19, the past slide is for COVID-19 red color, right? But for COVID yellow group, represent with mild symptom, or the patient with abnormal chest X-ray would be subjected to be admitted at hospital, which come from private plus hospital. It's called hospital. Okay, so at the hospital or field hospital or cohort ward, both need to be well equipped with oxygen ready to use. So those hotel who want to work with hospital, they need to meet the criteria to be the hospital. Okay. I think there is someone. Okay, just a question that you might have to ask me in the chat box. For the COVID green group, where they can help themselves, they can be at home, they have minor symptoms. So that favipiravir at home isolation will be suggested, or they will be suggested to be in community isolation. So it's depending on their readiness. If they're home ready for being home isolated, or if the community prepare the community isolated, we will assign them to be there. And we will have assigned health personnel to give them the basic, basic stuff for survival at home, 14 days, something like that. And for home isolation and also community isolation, that come as a result of village health volunteer, which is the highlight of my presentation today. Because as a result of high rate of COVID infected cases, where it needs a lot of health system supply, but healthcare personnel in our country is shortage for so long already. But the community health volunteer in our country then use as the best community mechanism for COVID prevention or guarding nationwide. Thailand WHO revealed that there are approximately 1 million village or community health volunteers that could call as unsung hero. It means that they are the hero, but they say nothing. They don't present themselves that what are they doing to support the nationwide. So the WHO in Thailand called them as an unsung heroes who helping guarding the community nationwide from COVID-19. And the Ministry of Public Health managed 1 million village health volunteers across the country, including 15,000 volunteers in Bangkok. Each volunteer will receive 1,000 baht, or about $32 per month only, and has received an extra 500 baht for an incentive during the COVID-19 outbreak. You can see that it is not the big amount of money, so that it's volunteer from their heart and their mind. For nationwide, the village health volunteer also help the government with contact tracing and quarantine when people need it. Isolate people who require home isolation or home quarantine. They also help to make sure that the people and business adhere to the COVID-19 prevention measure. And there will be the or directly to the outsider community who come in the community, because there would be a sign about heard the sound from somewhere. There would be a sign in families.
Jadi kadang-kadang nggak, karena juga nggak.
So that's the reason why they can see who is an outsider, because they get familiar with their area of responsibility already. For example, if I fly back to my hometown, they will be the first one who see that I am from the outsider and from another province that come from the red area or something like that, so that they will come directly to me and tracing about my history of contacting of COVID-19 patient or not, and report to the health promoting hospital or community hospital. And they have their own application, which I will tell you later. For this volunteer, they have been used as a key part of primary healthcare in Thailand during the past 4 decades already, not only during this COVID-19 outbreak. They basically undertake health survey, collect data, maintain family health records, and do disease prevention campaign to support the public health authority. In terms of outbreak of COVID-19, there are meticulous record of medical history of community members are used for contact tracing and health monitoring for the government. That's why we call them unsung heroes. The volunteer will knock in the door or household to give advice on COVID-19 prevention symptoms and self-observation, and hand out cloth masks that will made by their own masks, hand out for the community member, and give them the health flyer and alcohol-based gel. And during the height of Thailand battle against COVID-19,
we are sorry to inform you, Professor Naroemon, you have 3 minutes left for the presentation. Okay, so please make it on time. Thank you very much.
Okay. The volunteer were given face mask and face shield, biohazard bag, and alcohol-based gel for their protection. And besides that, the volunteer keep themselves updated about COVID-19 and operational guidelines through an app designed especially for them during the COVID-19 outbreak. And this is Dr. Daniel, who said that Dr. Daniel is the WHO national officer for its Thailand office. Summarize that Thailand village health volunteer are unsung hero, working to support the prevention and detection and reporting of COVID-19. He recognized the importance of the role that they have played in supporting public health in Thailand for more than 4 decades. And this is the last slide that I want to show you how the health volunteer work during the COVID-19 situation. If you cannot hear the voice, please feel free. I hope you hear the voice.
Okay. Thank you very much to Associate Professor Naru Emon from Mahidol University for the material. We are sorry to inform you that your time is running out for now. Okay, so now we will listen to our second speaker. Our second speaker, Nita Madhav from the Metabiota, San Francisco, US, before we move into the parallel discussion. Okay, so welcome to Nita Madhav. Are you here with us?
Yes, I'm here.
Okay, Nita, I'm very glad to see you. Welcome to our conference. Finally, after just exchanging email, finally I can meet you virtually. Thank you very much.
Yes, thank you for having me today. I'm very excited to be here.
Okay, before we start the presentation, I will tell about the regulation in this conference. Okay, the first, we hope that all of the participants should turn on their camera. And then the second, for those who have a question for the first and then a second speaker, to please write on the chat box, and then in the parallel discussion, we will read your question. And then to the speaker, you have 30 minutes for only for presentation, and then later we will have the parallel discussion. Okay, I will read some CV from our second speaker. Our second speaker, Nita Madhav, is from Metabiota, USA. She is the CEO or Chief Executive Officer. She has a lot of experience in research and then the publication as well. And then she graduated from like the American University dream of university. She graduated from a bachelor degree, Bachelor of Science in Yale University, and then a Master of Science in Public Health Epidemiology from Emory University. Okay. Now, Nita, now is your turn to present your material, please.
Thank you. All right, I hope everyone can see the screen. Thank you for having me today, and I will go ahead and get started given the time. So just a little bit about Metabiota. For those of you who may not be familiar, we're a company headquartered in San Francisco with field sites in Cameroon, DRC, and Sierra Leone in Africa. And we've worked in many countries around the world, founded in 2008, with a lot of history in viral discovery, capacity building, and now data science and computational epidemiology. We also value scientific engagement and publication. And you can see here some of our key partnerships for the work that we do. We provide cutting-edge data and analytic tools, quantifying the past, present, and future of epidemic risk. So we've done quite a bit of work over the past several years prior to COVID, structuring data from over 2,700 historical outbreaks. And we also track outbreaks in real time, including at any given moment, 60 outbreaks up to and thousands of others that we are continuing monitoring to see if they will pose a threat. We also do quite a bit of work developing indices on preparedness levels, fear scores, and other metrics. And we do a lot of modeling around how the future of epidemic risk, the frequency and severity and types of scenarios that may be possible could occur. So that's just a very tiny bit about what we do at Metabiota. So talking about COVID, I think it's really important to understand that COVID is not the first and will not be the last of the large epidemics and pandemics that could affect the human population. We have, starting even from 1918, Spanish flu, and up through time, many different other types of influenza pandemics, smallpox, different coronaviruses, Ebola outbreaks. All of these have caused different crises around the world. And just looking at COVID, the economic losses are substantial, with up to $9 trillion estimated in about the first year to 16 months of the pandemic. And according to a report by the World Economic Forum, these types of events have an average potential loss rivaling climate change. So this is a very large risk. And although COVID is an extremely serious event with many different consequences, it certainly will not be the last. There are many factors driving disease emergence. As many of you may know, there are lots of factors related to land use change, changes in the global transportation network, markets and trade, migration and conflict, resource extraction, water and food security, bioterrorism or even bioerror, and temperature changes associated with climate change that can all be factors driving disease emergence and point to a greater risk even as we move through time. So one of the studies that we've done recently was for the high-level independent panel on pandemic financing and for preparedness and response. So this was a G20 panel, and this work was done for this report where we looked at the frequency and severity of epidemics caused by wildlife zoonoses. So these are events that emerge from wild animals carrying diseases, including different types caused by viruses and bacteria that can then jump into humans and cause significant impacts and even touch off great global epidemics and pandemics. So what our research has found is that the number of events that are reported, along with the number of reported deaths, are increasing substantially, looking at data starting from the 1960s up until data to 2019, and then projecting to what the future might look like. And so we can see that although SARS coronavirus is a severe event, we may expect that there's actually an upward trend in the types of events that could occur in the future. So we've zoomed in these graphics to show, to highlight the trend in the observed data. And there are a few reasons for this trend that we're observing. So one is, as I mentioned, all of the different factors that are increasing the frequency of these types of spillover events and these types of zoonotic events. There's also, we know that there's been improved reporting over time, better systems for that. So that is playing a role here. But by and large, what we're seeing is really a true increase, even accounting for the increase in the number of reports and the improved reporting systems. Furthermore, when we look at the geographic distribution of spillover events, we can see that they're concentrated in many cases around areas of tropical regions, areas with high biodiversity, and areas that coincide with large human populations as well. And with the increase of megacities and increased human encroachment into wildland habitats, we do expect that these spillover events will also increase over time. And we can see as well that there are many points in Asia, Africa, and even South America. And the size of the points here is proportional to the number of spillover events.
Recording in progress.
One of the other studies that we've undertaken recently is to look at what we might expect for the next pandemic. Although COVID still continues, we also cannot lose sight of the fact that there are things looming on the horizon. So we want to understand what is the probability of another event as damaging as COVID-19. And it could be, we don't know, is it a 1 in a 20 year, a 1 in 50 year, and a 1 in 200 year? So this is why we went to do this study. So we want to understand these questions because this can help us to better plan and to be better prepared for events. It can help us to line up the type of financing that might be needed and to have the ability for surge capacity should it be required. It also points to the urgency and the priority to mitigate the risk. So this is a very important question and one that's not necessarily easy to develop the answer. For types of events and hazards that are well characterized with a lot of historical patterns and a constant risk, we can use historical data to provide a reasonably good estimate of the future risk. But for pandemics, these events are rarer, they're less frequent, and there's a high amount of variation in the severity. And furthermore, we can see biases in observed data. So we know that there's uneven reporting, there's underreporting, and so we have to account for that in any sort of analysis that aims to understand what the next pandemic might entail. So when we think about pandemics, this is a type of risk that we think of as tail risk. Tail risk means the part of the losses or events, the severity that is here in what we call the tail of the distribution. So if we're looking at the distribution of losses, meaning severity of these epidemics and pandemics, which could be thought of in the terms of economic losses, in number of those sickened, or number who die as a result, the pandemics, being these high severity, low frequency events, end up coming out into this tail, the catastrophic loss component of this distribution. The normal losses and the expected value that we would see for events that occur frequently on a regular basis are reliably quantifiable, whereas catastrophic losses require other methods for estimation, and are often underrepresented in the historical data due to a limited sample size. So in order to understand how to solve this problem, we will rely on simulated epidemic event catalogs. We use these catalogs to estimate the frequency of the events, the amount of losses that may occur, and we can also use this to look at what-if scenarios and to understand the impact of early action or other mitigation measures. When we develop these catalogs, we use disease-specific, stochastic, metapopulation, compartmental epidemiological models to simulate disease spread. And we incorporate data on emergence, risk, preparedness, public health interventions, and travel patterns. So we'll seed a location where an event starts. We will test many different permutations of these input parameters and simulate these over thousands of plausible events based on these epidemiological parameter distributions. Then, using actuarial analytical approaches, we estimate the likelihood of occurrence of any given event within this catalog over a given period of time. So again, here we're using modeled catalogs, and we're relying on the historical and scientific data to inform parameter estimation, but also accounting for what we know are some of the gaps and shortcomings of the historical data. We also account for trends over time, as we saw earlier, that there appears to be an increasing trend in this level of risk. And by running these types of modeled catalogs, it improves our understanding of the tail risk. So just for an example, if we looked at the historical record, if we looked at filoviruses or novel coronaviruses or pandemic flu, it's a very small amount, a handful of events. Maybe for filovirus, there's a larger number, but if we looked at novel coronaviruses or pandemic flu, we have essentially a handful. And so we really do need to augment this data set in order to understand the true level of risk. We take a probabilistic approach where we're looking at potential outcomes. We have to account for uncertainty because there are many factors that affect disease transmission, spread. There's many probability distributions for these parameters. And we would not be able to know what an exact outcome might look like or predict what the future might look like. But we can estimate which are the most likely outcomes to occur. And we're looking for a future view of risk, a prospective view. We want to understand what the possible scenarios might be, which will help us to inform preparedness planning, including stockpiling, hospital capacity, and financing. So based on this result, we actually have found that COVID-19 is not a once-in-a-century pathogen. So from the study that we did earlier this year, when there were about 3.5 million reported deaths globally, we estimated that the annual probability of this event causing at least this many deaths would be 2.5 to 3.3% chance in any given year. And if we look over the next 25 years, up to a 57% chance, which is much higher than many people might expect, given that COVID is often discussed as a once-in-a-100-year event or once-in-a-century pathogen. But these risk estimates show that this type of event is much more frequent than we may have previously thought. But the good news is that the risk estimates are able to be influenced and changed through investments in mitigation efforts such as surveillance, spillover risk reduction, and other methods of trying to prevent and mitigate such events from occurring. So for example, the impact of prevention. If we are looking at a 10-year period and we were able to reduce spillover events by just 1%, we might actually be able to avert a significant portion of deaths from this reduction in spillover. And so we certainly want to look at these types of methods and these areas for potential and deaths can be reduced by these types of early action. Now, switching gears a little bit, I think it's also important to note that infectious diseases are not just a health challenge. These are a societal challenge and have impacts that reach far beyond the health sector. They require a multi-sectoral understanding, and detecting and responding to epidemics and pandemics requires a wide range of capacities, including health, infrastructural, financial, and governance related. It also requires political will to effectively use the capacities, and international cooperation is another critical piece of the preparedness and response activities. One study that we also did recently for the UN Foundation was to look at the effect of international cooperation. For this study, we simulated counterfactual scenarios to model alternative trajectories that COVID-19 could have taken under varying conditions. We looked at potential downside scenarios where we looked at the types of health systems and multilateral cooperation that existed in the year 2000. And then we compared it to what we observed happening over this past 16 months. And then we also looked at an upside scenario if the pandemic had occurred when there were stronger systems for cooperation. We looked at the potential impacts in terms of infection, ended up being. We looked at systems like institutional, legal, normative, coordination, procurement, and financing, and the types of mechanisms that were impacted here, including communication and scientific collaboration, support for lower-income countries, and vaccine therapeutic development and distribution. So we've seen many successes during COVID, and I think we want to make sure not to lose sight of a lot of things that did not go wrong, actually were better than may have occurred in the past. So looking at things like information sharing, genomic data sharing, strategic preparedness and response plans, open collaboration. There are also areas where there could have been better systems in place, better planning, and better collaboration. So we have to kind of keep in mind that there's two sides of the coin here. In support for lower-income countries, there are some successes: Africa CDC, HHS, HSS, and then surveillance lab and diagnostic capacity. And on the response side, the procurement and the COVAX have been counted as successes. Now, what could have been better is more investment in health infrastructure and capacity, more collaboration between countries, and more equitable vaccine distribution. So in the modeling itself, we looked at, as I mentioned, the kind of base case scenario, which is what we saw for the pandemic through mid-February 2021. And then we looked at if we had a year 2000 type of international system, before 2005, international health regulations reforms, before major improvements to outbreak detection and global information sharing. So that's one of the kind of worst case scenarios. And then in the better case scenario, we looked at if there had been better multilateral cooperation that would have improved the speed of control, of detection, and possibly as well with improvements in the timing of vaccine development and deployment. So the results shown here are also available in the UN Secretary General's report that came out earlier this year, where we looked at if our international cooperation systems had not been as robust as what we had in 2020, but rather looked something closer to year 2000, we would have likely or potentially seen losses as high as 7.9 trillion instead of the 5 trillion estimated for the first year of the pandemic. And the global death toll could have been as high as 19 million reported. Whereas if we had had better international cooperation, assuming vaccine development and approval could have happened more quickly, and other coordination mechanisms could have led to faster information sharing, we may have seen as little as $2.7 trillion of loss in the first year, and maybe as little as 1 million for the total death toll. And so you can see from this study that international cooperation is a critical piece of this type of global pandemic response. So lessons learned, after every epidemic and pandemic, there's often a lesson to be learned. But we've also seen that there's a typical pattern, which is collective amnesia, unfortunately. And while data can facilitate the lessons learned and can help with risk mitigation in the future, we can identify failure points. We can use this to inform greater public health investments in other sectors, insurance solutions, social bonds, financing mechanisms. We can create incentives and systems to nudge decision makers out of the cycle of panic and neglect, which so often occurs. When there is an event, there's a panic, and then soon afterwards, there's a neglect that occurs and funding falls by the wayside. And that's something we certainly want to avoid occurring after COVID. So what we really would hope for the future is to move to a more proactive approach, away from the reactive approach that the world has often taken to these types of events. We want to be able to do more prior to an epidemic occurring, identifying appropriate data sources, constructing simulation models to support risk analytics, planning and decision making, increasing preparedness, creating contingency plans. And on a broader scale, looking to the future, we have to take the lessons from COVID-19. We have the opportunity now to embrace more proactive approaches to biosecurity. We don't want to lose sight of the linkages between epidemic and endemic disease. Although certainly COVID has had a very high death toll, untold are the numbers of endemic disease deaths that have happened as a result because of people not seeking healthcare due to the pandemic, vaccines that have fallen by the wayside. And in fact, in many areas where there have been gains against endemic diseases such as diarrheal diseases, HIV, we now might see those gains be lost as a result of the COVID pandemic. We want to start seeing new systems and bringing to bear a lot of the technology that's been developed when it comes to platforms, when it comes to data science. And we want to start to see the world moving at machine speed rather than human speed when it comes to trying to make decisions about these events. A lot of times what we see are a lot of decisions made by committee. There aren't necessarily the types of AI and technologies that are brought to bear to help with understanding how to make those decisions more quickly and respond in real time instead of responding with a 2-week lag or a 5-week lag or even longer. We also are now thinking about different types of surveillance systems that have more of an always-on quality. rather than having a system that gets stood up specifically in a time of an epidemic or pandemic. It will be a better system if it's something that is always working even in the inter-pandemic periods. And surely it can scale up when the need arises, but a system that's constantly doing this surveillance and really detecting and spotting things that may, on those very early times when something just emerges and becomes apparent, because the early action is really the key to stopping something like this, like COVID, before it gets out of hand and impossible to contain. And then the fourth point about the lessons from COVID is about thinking globally and acting locally. Now, we saw earlier that international cooperation and a global approach is critical in an event like a pandemic, where every corner of the earth is impacted. However, we also know that the solutions often will start at the local level, the implementation, the contact tracing, and all the other measures that are occurring are happening really at the local level, at the person level. And so we need to ensure that when these systems are stood up, that they account for all of these factors of the local context, and that the system is interoperable globally, but also works locally. And, finally, to close, that we really must take these lessons that we learned from COVID and prior events and put them into action and not fall into the trap of being in the panic and neglect cycle. So that is all I had for my remarks. So I thank you very much for your attention.
Okay, thank you very much, Nita, for the great presentation. I'm quite surprised with your presentation actually, because from your presentation, I know that COVID-19 is not that rare actually. And then for the future, another pandemic will be very probable to come very soon. Okay, thank you. Okay, so now we will move to the question and answer section. Okay. Okay, I will check some question on the chat. We are sorry, it's quite mixed between the question about between the chat about the question and the other type of chat. Okay, so I will ask some question. Maybe the first is for Associate Professor Narwemon first. The question is, how is the hospital condition in Thailand when the COVID-19 case is very high? And then how about the PPE, personal protective equipment, how the Thailand manage the hospital service need when the COVID-19 case is very high? Now it's please, okay.
Thank you for the question. I have already typed for some question in the chat box already, so that I will answer about the question that I haven't answered yet, which is the handle of the hospital during the crisis of COVID. During the crisis of COVID-19, especially in the in the first, second, and third wave, we have the shortage of ICU for COVID-19 patient, and also the shortage of healthcare personnel, especially nurse and also the doctors. So that's the reason why we group them into three group. That if you recall back about my slide, the first group of COVID infected is the green group, and the second one is the yellow group, and the third one is the red group. So the red group will be those patients who admit in the ICU of COVID ward. So for the yellow group, which is have some chest X-ray abnormal, they will be assigned to be hospital or in another alternative quarantine that are equipped with oxygen enough. So that's make the situation get better after we decide to group them and assign them to particular quarantine.
Okay. Thank you very much, Associate Professor Narwemon, for the answer. Okay. The second question, maybe I will talk to Nita about the underreported cases. So here in Indonesia, some government, because they don't want the society to be panicked because of high case of COVID-19, they intentionally don't report the actual number of COVID-19 cases. So is that common also happen in other side of country? Do you have any comment on this?
Yes, it's actually a very significant problem, in many parts of the world. There are some countries that have reported no COVID cases, which doesn't seem correct, doesn't seem possible. So, we have that situation. So there's a kind of a deliberate or a politically induced underreporting. There's also the factors related to, a lot of time what gets reported is what is, what reaches the health system. Which groups have health-seeking behavior, what actually gets seen in some sort of a clinical or public health setting. So that's another factor related to underreporting. And so what we've looked at, we've actually done a study on this, which will soon to be published, about what factors are related to underreporting the most. Some are related to the pathogen itself. We find that deadlier pathogens are actually more likely to be reported. What sort of political factors are associated with reporting or underreporting, and then what sort of health system factors. So, taking it all together, again, this is another one that is, I think, a whole systems issue. It's not just a health issue or a data issue. It really is a whole system issue. And so what we can do is we can correct for some of that, given what we do know about the underreporting that's occurring. And in the end of the day, the question is are the data sufficient enough to be able to make the types of decisions that we need to make? If it is, then even though the underreporting is a problem, it needs to be corrected, it may not be as critical of an issue if you're looking for a qualitative sense of what's going on. So it really matters what you're trying to do with the data, and then you can adjust for known factors that might lead to the underreporting.
Okay. Thank you very much to Nita for the comment. I will go back to Associate Professor Narwemon for another question around the COVID-19 management in Thailand. Okay. Okay, wait for a second. I find some interesting question here. Okay. Like, how is the false information spread in Thailand, and then how a government manage the hoax and then false information to make people is more easy to do the health protocol, and then it's very easier to manage the vaccination. That's the question.
Yeah, for vaccination, of course, at first I have hesitated to get vaccinated because of the side effect that the television or the media try to show the news of the worst effect that happened to the Thai citizens who get vaccinated. But anyway, the government work with the Ministry of Public Health to ensure that the vaccine is safe enough. That they ask the healthcare personnel like medical doctor and also nurse to get vaccinated to be the front line or the first tier of get vaccinated, so that the Thai citizen will be feel like okay, it's safe enough. But still, they have some hesitate because a lot of media always throw some advertisement about the bad side effect of vaccination.
Okay.
Right.
Okay, thank you very much, Associate Professor Naruemon. Okay, I will go back to Nita. Like from wait, another question is, it seems like that the pandemic will become over and over. We don't know, maybe COVID-19, maybe like another pandemic can become anywhere. Is there any way we can stop it? Or if we can stop it, actually, what is the best preparedness and response for the future pandemic? Thank you very much.
Oh, so it's a good question. I think it's we could spend another hour talking about that even. But I think for pandemics, it's really critical to have prevention and early action. The earlier that you can find out what is happening, to have situational awareness, to have these surveillance mechanisms in place, this is when is the chance to really do something to stem the tide of an event of this magnitude before it gets this big. So there's been discussion, by WHO that the February of 2020 was a lost month. That was a month when there perhaps was a chance of containing COVID before it became really impossible. And so the key is really to have these type of surveillance systems, to understand what is circulating and what could become a pandemic and what causes things to become a pandemic. I think there's still a lot of research that could be done in this area to better anticipate what those risks might be, and to then have the types of surveillance mechanisms in place. I think an always-on system is one that would really be beneficial, because you would not only would you have knowledge of when something was happening, but you would have this baseline view of what's normal. In many cases, we don't actually have a good baseline of that, just due to a lot of infrastructural constraints and the way that systems are currently set up. And so moving towards a system that's more of an always-on, constantly monitoring, I think is really going to be an important key to this in the future.
Okay, it's a very hard question and a very hard answer as well to do. Okay, I will go back to Associate Professor Naruemon. Okay, could you please tell us how the testing policy and then quarantine policy currently in Thailand?
Sorry again, please.
Okay, could you please tell us how the testing and then the quarantine policy currently in Thailand?
You mean vaccine policy, right?
Testing.
The testing, the PCR,
the testing and the quarantine policy.
Just typing already in chat box. We are now have ATK toolkit to provide them at the pharmaceutical shop that is affordable price that can test it by their own among their family members, so that if they suspect themselves that they may have some symptoms, they can buy from the pharmacy shop and test it by their own. Easy way to do that. But if they have some history of close contact with COVID-19 people, or they have some symptoms, and they can get RT-PCR for free from any hospital. But you cannot go directly to the hospital and get RT-PCR. You can go directly to the hospital to get RT-PCR in case that you are at risk and you have already been assessed that you are really at risk.
Okay, thank you very much for the answer, Associate Professor Naruemon. Okay, I will go back to Nita. Okay, Nita, please tell us why the COVID-19 pandemic is so catastrophic. Like it's even not comparable with H5N1 and then the MERS and then H1N1. Why this COVID-19 is so catastrophic? What happened actually? compared to
Yes.
the other type of pandemic?
Well, I think with any sort of catastrophic event like this, there's often a cascade of events and failures that reach up to lead into something, it's a snowball effect. It's not just one thing went wrong, many things went wrong. And so I think that we see this with COVID. And there are certain factors about the virus itself that make it different from many of the other ones that we've experienced recently. So, for example, the fact that it can spread even from asymptomatic or pre-symptomatic patients. That makes containment extremely difficult to track. By the time you or the world figured out what was going on, it was likely already spread to many locations due to that. That it was a coronavirus, which we hadn't had as much experience with, and that coronavirus especially show this propensity for super spreading or for this, not necessarily spreading evenly to all contacts. And so I think some of those things put a damper, kind of made it hard early on to understand what was going on, and then led to a lot of delays. And then, suddenly you also had, I think, the political climate, the cooperation, while better than what we would have seen in 2000, certainly there could have been areas where it could have been improved. I think with any large event like this, we also see that there is a lot of, countries don't have the capacity to go and really help other countries. It becomes very internalized, and every country is, very concerned with their own situation and their own problems. And so that's something that we often would expect to see in a large pandemic, because the country first duty is to its citizens. But I think that also contributed. And so we had a lot of systems that have, due to lack of funding, due to this panic neglect cycle, actually weren't up to the task and weren't at the level of preparedness that would have needed to be there. But I think now that we've seen this, we know this, I think we can make improvements in the system.
Okay, thank you very much. Okay, maybe one more last question, one for Associate Professor Narwaemon and for Denita. Okay. Last question for Associate Professor Narwaemon. What are the real steps to educate people in Thailand about COVID-19 pandemic?
You mean the step?
Yeah. What are the real steps like to educate people that maybe best practice in Thailand on it to educate people on COVID-19?
Okay. You mean in general, people in general, right?
Yeah.
Okay. At first, it's really, how to say, it's really messed up that the information is overloaded from everywhere, and people get scared a lot, and they feel unsafe everywhere. So that is like the period that is very, how to say, very uncomfortable a lot for that crisis. But we passed that condition because we together try to help each other. Just like I mentioned that community health volunteer is our voice that go directly to the lay person, first of all, so that it's quite easier for us to maintain how to say up-to-date information for our citizen in general. Even though some citizen is not believe in the government, or even they don't believe in the Ministry of Public Health, but after we got our unsung hero of community health personnel that which is work with the community that surrounding them, it's much easier to make them understand about the COVID situation and the pandemic, and also the protection by using the MHTTA, just like I mentioned in the slide.
Okay, thank you for the answer, Associate Professor Narwaemon. Okay, maybe the last question to Nita. do you have any comment or suggestion specifically to Indonesia or maybe other developing country on prepare and anticipate the future pandemic? Because like, you know, developing country has like very specific situation. We don't have a lot of money, resources and so on. Do you have any comment?
Yeah, I think one thing that's come up a lot lately is about how to develop local capacity manufacturing for different types of supplies, vaccines or therapeutics that might be needed during a future event. And I think there's a lot of work going on there to try to give countries capacity to do this, to build this type of local infrastructure. So I think that's something that will probably figure prominently for the future. And that, the question right now is, will these types of local manufacturing, can they also operate in the inter-pandemic or, regular times? And, I think there are ways that it can do that. The other component as well is just the general health system strengthening, which I know, the resources for that are very scant, but there are ways to improve that system and to utilize some of these more efficient approaches, partnering with international organizations that are working to bring these types of capacities to these regions. And so I think certainly the priority needs to be placed on these types of infrastructural and health system improvements and investments that, we've seen over and over again that like these early investments in preparedness are, very much more, have a higher return on investment than any sort of, response or after an event began. So I think, when it comes to where to allocate even these, scarce dollars, I think looking for areas that can improve overall health systems and improving the levels of preparedness and these detection and early action, I think those are the areas where the focus needs to be.
Okay, thank you very much for two of our keynote speakers, Associate Professor Naru Emon and Nita Madhav. Thank you very much for coming to our conference. Okay, I think first I need to state the conclusion of these two presentations. The presentation from Associate Professor Naru Emon, the key to manage the COVID-19 pandemic is the community participation and community development. And then so it is very important on how we engage the community to work together to face this pandemic. And then for the presentation for Nita Madhav, I can conclude that actually pandemic is not that rare. It is very possible for next pandemic to come over and over. Maybe in the next few years, it is very possible. So as a developing country, we have to prepare. We have to increase the local capacity, and then we have to do that a lot of partnership as well around the world. And then of course, because of we are here developing country, setting priorities is also important. Thank you very much for the two speakers. Once again, Associate Professor Naru Emon. This is the certificate of appreciation from us for your coming speech and your sharing experience in this today conference. And then this is the certificate for the Nita Madhav from the Meta Biota. Thank you very much for coming, for sharing your insight, your experience, and then your research on the COVID-19 and then about the future pandemic. Okay, thank you very much. I am Riza Yulawati as the chairman or moderator for this first session. Apologize for any mistake or any inconvenience that I make in this session. We will move to the next agenda. Thank you very much. Good morning. Wassalamualaikum warahmatullahi wabarakatuh. Thank you very much.
All right, thank you.
Okay, thank you very much, Nita. Thank you, Associate Naru Emon. Thank you very much for coming. Thank you for sharing.
You're welcome.
Okay, thank you for Associate Professor Dr. Nairemon Aunoreku. Okay, thank you for the Associate Professor Dr. Nairemon from the Mahidol University and Mrs. Nita Mada from the CEO of Metabiota San Francisco, USA. Ladies and gentlemen, the next agenda is the second symposium. We will deliver two topics presented by Professor Dr. Sandep Podar, PhD from Lincoln University College, Malaysia. And then the second presenter is Mr. Dr. Sendat Imam Suprapto as Director of Strada Indonesia. And the discussion will lead by the chairwoman, Mrs. Eva Agustina, Magister of Nursing, and with the co-chairwoman, Mrs. Asrul Yasani, Magister of Public Health. Times for yours.
Good morning, Miss Eva. Unmute. You are in muted.
Okay, good morning, Mr. Sandeep.
Good morning.
Okay, so how was your day?
Yes, fine.
How's Malaysia now with this pandemic COVID right now?
Yes, now vaccination is completed almost for the adults.
Oh.
So now they started under 18 and now trial run for under 12.
Oh, it's really nice then. So it almost finished about vaccination.
Yes, and opening the state border also, they opened.
Oh, so I can go there again.
Yes, I think now started already.
Okay. Okay. Thank you. First, I would like to say thank you for Mr. Sandeep because today you have spared your time to join in our conference for today. It's really a great honor for us. Okay, let's start our session for today. Good morning to all the respectable speaker, the honorable all participants of this conference. Please introduce, my name is Eva Agustina, and I will continue as the chair or moderator in this session. And ladies and gentlemen, before we start our session for today, let me introduce to all the speakers for this session. For the first, we already have Mr. Sandeep Podar here. Good morning, Mr. Sandeep. Okay, please say hi to all our participants.
Good morning and good to all the participants, and I think good evening to US, madam.
Yeah, for Miss Madam.
Yes.
Okay, and then for the second speaker after Dr. Sandeep, we also have our rector, Dr. Sentot Imam Suprapto. So maybe to take our time, let's start our presentation. But before we start our presentation, for the first, I would like to read the curriculum vitae for our speaker. For the first, I already have the curriculum vitae from Dr. Sandeep Podar. Here we have Dr. Sandeep Podar with us. He is from Lincoln University College and right now in Malaysia. Is that right? Okay. And then for now, Dr. Sandeep lives in Dixon Lake, Kolkata, India. Oh, so you still as Indian, yeah? Okay. Okay. For his educational qualification, Dr. Sandeep, right now, Dr. Sandeep graduated from University of Calcutta, Kolkata, India. And then his Magister of Science in Zoology. He is also graduated from Dayalbag Educational Institute, Agra, India. And then his PhD, he is finishing his PhD in University of Calcutta, Kolkata, India. And Dr. Sandeep also graduated from Master of Business in Lincoln University College, Malaysia. And for his research experience until now, I think Dr. Sandeep already have a lot of experience about research. It's very amazing experience. I think you can share all the experience with us today. And then his special duty right now, he is as a Deputy Vice Chancellor of Administration in Lincoln University College for about 6 months. His job responsibility is to control the administration as well as to make international collaboration by working closely with the management. And Dr. Sandeep also worked as a Director of Operation Lincoln University College for about a year. His publication, Dr. Sandeep already have a lot of publication in a lot of international journal, I guess. And yeah, and for today with his background, he will share a very informative topic for us, and we will hear the presentation from Dr. Sandeep after this. But maybe before we start our presentation, maybe Dr. Sandeep, what do you think about pandemic situation, pandemic COVID-19 situation in Indonesia right now? As an, how about your perspective, especially in Indonesia?
So, thank you for introduction, but I make a little correction that I am Deputy Vice Chancellor in Research and Innovation.
Oh, in research, sorry.
And of course, I am staying here more than 12 years in Malaysia, and graduated from India, that's of Calcutta University. And as per Indonesia, I heard that the cases is still rise and the vaccination is still ongoing. Adult population is still ongoing progress in vaccination. And as per the crowd of the country is more, so the tackling of the COVID condition also is problematic.
Yeah.
So that's my perception.
Yeah, I think that's correct. Okay, maybe to take our time, we will start our presentation first with Dr. Sandip. Dr. Sandip, you have 20 minutes to present your article. Please take your time.
Thank you. And I first share my screen.
Yep.
I think everybody can see my screen now.
Yep, it is already on our screen.
Okay, thank you. So we are here today. All the participants, I see that are hearing more than around 1,000 of participants. We are here in the third Strada International Conference on Health, and we are discussing on COVID-19 endemic, opportunities, threats, preparedness, and adaptation. In this aspect, we are discussing different aspects from different countries, and I shall discuss what we all already know, that aspect, not any unknown thing. I will discuss on the known things, and we have to focus on that only to get our life easier in this new normal condition. As first, we will discuss about the stigma. Stigma in different forms. From the starting of COVID till date, now, and in ongoing, in means future also, we have to go in different types of stigma during this adaptation and preparedness and what you call in this time. Like, for example, when the COVID started in last year in March or etc. Time, that time everybody in other countries, Indonesia, India, or Pakistan, everywhere, other countries of the world, they are thinking that from where the means virus coming. It is from China, and it may not be spreaded to the hot countries like our temperate region, Malaysia, Indonesia, etc. It will not spread because it is a disease of cold region. So we are not given any awareness, means we are not given any protection measure and thinking about that it can happen in other countries as well. So as soon as we don't focus on that, we don't believe that. So the outcome is, we already know that all countries affected, and we don't have enough manpower and equipments to fight against the COVID. So people in the forefront, like the health workers, police personnel, then the what you call cleaners, they at the front warrior, they have to work every day, and they are all isolated from the society in the beginning. Last year, we can remember that the health workers cannot come at home. If they come to home, the area persons, locality area neighbors don't allow them to come inside the home. So the doctors and nurses spend their times in hospitals, in the toilet, even when they are borrowing the bodies, in the dead bodies, they have so tired, they have to rest in their place itself, in the car itself. Not, they cannot go home. It is, of course, there is a stigma that the neighbors and the society give to these persons. So there are different newses comes. I give example from not only from Indonesia, Malaysia, it is from US and etc. That you can see the nurse attacked on her way to her work, suspected believed that she is exposed to community of COVID-19. The nurse cannot go to home. They have to take care from far the children of their home itself, and they have to hire other person to keep their home things running, because they are also human beings. That not that they don't have any family or etc. So there is stigma based on profession. Then we come that yes, of course, the nurse also have to take care of baby, etc. This picture I have taken from Facebook. Many of you have seen maybe this type of condition. Then stigmatization of the suspected and actually infected individuals. Anybody sneezing or coughing, we thought that yes, he is affected with corona or everything. But it may not be true. And who is real affected, we are not giving any focus on that. So the spreading is more. I see in the last session one question arise that why the COVID is still spreading. This is one of the reasons that COVID is spreading. We will discuss again in future, but this is the stigma that we think that yes, this person is affected. So then there is a stigma that religious identity. That in Malaysia and India we have heard that okay, the people joined for some religious activity, for mosque or church or in what we call the Hindu rivers, etc. They are affected and they are spreading the disease. Of course, the crowd is spreading the disease, but it is not that any crowd. It is any crowd that is affected with this type of means spreading of the disease. So it may be in mosque, it may be in political activity rally, or it may be in sports, recreation, etc. You can see that last year there is a spread, means 4th July, the American US Independence Day. In this year also, the people go to sea beach and there is crowded sea beach we can see. Even last week, I have not last week, last week I have traveled to here on nearby sea beach in weekdays in Malaysia. It is crowded. That no person is based on isolation, etc. in the sea beach. So there is a stigma. Main is change of behavior, change in the behavior. That the person go to shopping mall, they don't want to be tested for temperature, they don't want to wear mask, they don't want to use hand sanitizer. So they are questioning that it is my constitutional right to go in. No mask, no service, I don't believe. Then there is another stigma that I don't take vaccine. Why? Because it is leaf attenuated vaccine. So it may be they are infecting us with corona. So it may damage us more. It may infect us with corona. So we will not take vaccine. Even I have seen many countries don't start the vaccination quickly because they want to see that other country is taking vaccine. So what is the outcome? And you know that India started the vaccination in January 2021 itself, but still now there are many persons don't bother to take vaccine. Even the vaccine is open, there is no queue, etc. The vaccine is there in lot of amount, but the people is not moving to take the vaccination. So there is a freeze in the change of behavior that I don't want to take vaccine. Even myself also, I was thinking that which vaccine have to take on. Many persons here also Malaysia have 3 vaccines, Pfizer, Sinovac, and of course AstraZeneca. This 3 type of vaccine in Malaysia. And then people is thinking that which vaccine have to take. I don't take AstraZeneca. I will not take what we call Sinovac. I will not take Pfizer. But the meaning is the outcome is they are delaying the vaccination process. And we have seen the results that even the person is double booster, means double dose with Pfizer, the person cannot come back from the ICU. So this type of example is there, that not that Pfizer vaccine is more protective than Sinovac. It may be questionable, but Whatever vaccine is getting, we should get the vaccination done first. It is not that we object, we don't take. So this is a stigma, that behavior of us, we don't take the vaccine, we don't want to accept. And we don't want to test. Even why? Because we want to go for holiday, etc. And we want to get out from this monotony of lockdown, from long days. We are disrupted economically, we are disrupted mentally, and we are disrupted educationally. We are going online. It is a good thing that sitting in Malaysia, I am talking with all of you in different parts of Indonesia. You are here and thousands of people can listen. It may not be possible in physical activity. Physically, thousands of people may not be accommodated in one hall so quickly and on time. So these are the things causing monotony in our life. And of course, why we not testing still now? Many persons get fever and etc. They still stay at home. Why they're not testing? Because for social isolation. They are feared. Because if I tested positive, then my home will be quarantined and no person will be service for giving service to our home, and we will be isolated from society. I cannot go out from home. So these things. But if I cannot, means if the person is not tested, and you can understand, or you can understand easily that if I am not tested and COVID positive and I want to go out from home, that what is the thing I am giving to other persons? I am going to holidays without testing and I am with the crowd, I am moving around here and there, and I am infected, I am spreading the infected without knowing to anybody. So this is the main cause of spreading of disease. So there is stigma based over the death. Then the people sometimes they don't care that dead body cannot be buried here, dead body cannot be burned here, like that type of stigma is there because it will spread the COVID. So the people have to make shift, the government have to make shift to that arrangement, that where the dead body can be buried, where the dead body can be burned, like that makeshift arrangement for the funeral of the dead bodies. Then we have from WHO, the social stigma in context of health is the negative association between a person or group of people who share certain characteristic and specific disease. Then in an outbreak, this may mean people are labeled, stereotyped, discriminated against and treated separately. So experience of loss of status because of perceived link with the disease. So this is the WHO also have listed these factors in their documentation. You can see in SICH in the website that such treatment can negatively affect the caregivers, family, friends, and communities. And people who don't have the disease but share others' characteristics with the group may also suffer from stigma. So the current COVID-19 outbreak has provoked social stigma and discriminatory behaviors against people of different ethnic background, of course, of different religious background, and I can tell that yes, this disease is from China, this variety is from India, like that. But it is not that. The disease is a disease and it is caused from where, maybe originated from China, we are not sure. So that, but that does not mean we segregate all in whole world people, segregate one person like separately. Now everybody is affected, so everybody is same affected with the disease. So we have to give a blank eye rule to everybody. Then the level of stigma associated with COVID-19 is based on three main factors. It is a disease that's new and many of the things are unknown. We are often afraid of the unknown and it is easy to associate with confusion, anxiety, and fear among the public. So these are the fueling factor of the COVID-19 information. Now we know this graph. We previously in comfort zone that feels safe and comfortable, that no, nothing is there. Then when COVID comes, we are in fear zone and we have lack of self-confidence then we are in learning zone, that dealing with the challenges or problems, that how we can cope up with this new normal. Then only if we accept the new changes and prepare for the new normal, then only we in the growth phase. Now we are in that phase that we are moving and we are opening the borders again, that everybody can come here and go outside from other country to other country. So this is the picture. We also can demonstrate by the Kubler-Ross grief cycle, that first we deny that it may not affect us, it is a colder region disease. Then we have, when it affects us, then we are angry that, oh, these China people bring this disease, we are not safe, and this is the religious activity that bring the disease. We don't think that I don't wash hand, I don't wear protection measure, I don't have taken protective measure, so I am infected. We don't think that the disease is transmitted in the animals also. The what you call, the other mammals also infected. So how we think, when we are affected, then we are angry, then we are depressed that we cannot go out from home, we cannot do anything, we are jobless, many things happening, and the disease is not going out. We have no choice to stay at home. Then we started bargaining that how we can go out, we have to take vaccine, we have to wear mask, we have to hand wash, then we can go out. Then we have to accept, yes, the disease is there and we are here, so we have to take preparedness and actively change our habit and tackle the new normal situation. So, as I told, the depression is there, and this causes many joblessness, this COVID-19 period, and many persons commit suicide due to this economic depression caused by this COVID. This is a mental health, problem during this COVID. So when we are no longer able to change the situation, we are challenged to change ourselves. It is studied by Dr. Professor Viktor Frankl. He is a survivor of World War II prison and professor after that. So he gave this theory that when we are no longer able to change ourselves, situation, we have to change ourselves. So how we can change ourselves? We cannot change our behavior so easily. You can see that when we are closing our hand like this, if you can try that, okay, left hand, right hand, you cross like this, then you can see one finger, maybe right hand, or your left hand thumb will be up. You check, open the two hand and join. Then you can see somebody's is right hand up, somebody's maybe left finger up. Again open, try to up other finger, then you will feel difficulty. When you are taking food in right hand, take the food in left hand, you will find difficulty. Writing your left hand, you try to write in right hand, you will find difficulty. So these are the change, but we can do. Change is not easy. As we find difficulty in changing our hand, the change of our behavior is the most difficult thing. So what is the preparedness we have taken? Just, I think I have more 5 minutes, so I will finish within that. So what is the changes? This is the picture in Lancet that we have made. Different countries have made their stadiums, makeshift hospital for COVID. And in China, the makeshift hospital have been now barren, and now they have tackled. Now other countries also same. The makeshift hospitals have been for the stadium, they make converted to hospital that have been now vacated because the patient case is reducing. Then in Indonesia, they have discovered that the isolation chamber where the patient will come and will be treated like that. They will take out the gloves inside, and the person will not contact with the patient. Any patient come in the clinic. So this is a chamber. Indonesia have patented this, and many of you know maybe, and this is very effective. Then we have changed. We have to cover our PPE, etc. Everything wearing mask and then drive-through testing. We have to make social distancing during queuing up. These all changes, preparedness we have taken up. Then in Malaysia, you can see the vaccination center. After vaccination, they have to wait for 15 minutes. They have made many halls they have made for this vaccination center, and they quick vaccination. They make a time appointment. You reach by that time, and suppose I have given 12 noon. I reach 12 noon, and within 5-10 minutes, I will be vaccinated and wait for 15 minutes to see, observe, and then I can go out. So this is a very systematic approach they have taken for vaccination, and you can see the very nice condition. No queuing up like that. If some people, of course, if I have time at 12, I have to go 15 minutes earlier, so that queue is there. Not that so much rush that I have to beat another person to get the vaccine like that. So now we have taken measures to sanitize our litter box in many places, in the gym or in the other areas, cafeteria. Even, of course, you can see in this right hand side, this picture, it is a robot now serving food in Malaysia restaurants, and you order the table number, the robot will come and give the tea, coffee, and etc. There is no person is coming to check over the disease. And in Indonesia, you can see this robot is there. It is Reuters have been shared this news that this is made from household what we call waste things. It is not that very expensive things they make this robot. This is making spray, the sanitizer, giving food, and of course they have a TV monitor and etc. etc. So this is a robotic approach the Indonesia in the village they have made. And Malaysia, we have seen that there is a queuing software we have taken. Many softwares is coming up in this time, and like this Zoom platform and other software we are talking, and then queuing software is there. In bank, if you have to go, we have to make a queuing. There's this branch, I will go, what time, and then what is the purpose I am going, and accordingly the time will be, ticket will be issued, and I can go next day or 15 minutes, after that 15 minutes. So I don't have to queue in bank. I go and show that my ticket is there in my app and I can go in. So there is a queuing software, and of course there is another software that is controlling that this stigma, that is my Sajatra in Malaysia, that how if I want to go any mall or any shop, I have to scan the code. I cannot simply write the name in the book and go in. I have to scan, and I have to change my profile in my Sajatra app. Then if I scan, then there is in the app we can see what is my profile. I am vaccinated or not. If not vaccinated, it will show red. I cannot go in. If I am fully vaccinated, yes, I can go in. Then if I am in contact with anybody, like that my previous speaker from Thailand telling that there is a trackability of contactness. So I attend any contact with the COVID-19 patients and etc. My profile will be changed, because the scan app will detect that I have reached, means I have get contacted with COVID-19 patient. So I will be 14 days quarantine, and that will be shown in my profile that my chances is high. I cannot go out and I cannot go inside any shopping mall. I will be in home quarantine. So as soon as it is captured in software, I cannot go out anywhere, because I have stigma that I have not infected, etc. So I can go in, but the software will not allow me to go any other places. So this is a very useful software by government, and this vaccination, first vaccination, second vaccination, what is my status of infection, everything can be seen in this software. Even I entered in our university, and in my apartment in condominium, I had to scan the software that I am entering there. So how, from when to when I am here, I am in my house, it will be monitored in this software. And of course, there is, you can see this, many person from, maybe not from this university, in Strada, Indonesia, that in this time, there are different types of application, innovation come up. Like the pharmacy, you can see this.
Yep.
That the community activity they have done, like the citronelle, the formulation of citronelle, the oil, and it is a known thing that it, what you call it, it keeps away the mosquito and etc. So in this time, there is a disease of dengue and malaria is increasing. So this is a very good initiative taken by Strada Indonesia, and this type of thing is coming up during this time for the preparedness of new normal area, because it is not that we are thinking only about COVID-19. There are other associated diseases which we are forgetting, and that is still there. So it is very good approach that we are tackling the thinking about the use of citronella and etc. for the household, means in the villages, in the community level. So it is a very good approach, and this type of approach everybody should take and think that yes, that other disease how we can tackle. Then you can see that previously in 2020 the business index was lower, as Ms. Eva was asking about my conception about the Indonesia. Yes, Indonesia cannot export the what do you call it? Malaysia cannot export pig to Singapore, but Indonesia export pig because the border was open. So there is a business rise during, there are different types of business hamperment during this lockdown time. So business was down in 2020, and but 2021 it is now recovering again. So we are struggling for existence. Survival of the fittest is already known, and who will survive, that is to be detected by the natural selection. So Charles Darwin struggle for existence, survival of the fittest, and natural selection is there always. And thank you for the Strada Indonesia for giving me this opportunity for talking, and of course the main organizer Muhammad Ali Sodi, and of course the coordinator and the chairperson of this session, Ms. Eva. Thank you again, and all the participants to attend this gathering in this session. Thank you again.
Yeah. Thank you very much, Mr. Sandip. I think it is a very informative and interesting presentation from you. So from here, I could make a conclusion that not only in Indonesia, but I think in almost all Asian part, still thinking that COVID-19 at first, COVID-19 is something to be feared, but some people also doesn't believe that it exists. But now people start to change. Maybe like you already said that, but the most difficult thing is how to change our behavior. So yeah, maybe from now I could see that some people around me is really eager to go out, go to holiday and everything. So the government have to make a new policy about traveling, about everything. But some people also deny that policy, and it does not only happen in Indonesia, but also happen in another country. Okay, so once again, thank you for a very nice information, Mr. Sandip. Before we, I think we have a lot of questions for you, but before that, maybe I will continue our presentation with the second speaker. Everyone, please welcome for our second speaker. We have our rector, Bapak Dr. Sentot Imam Suprapto. Okay, good morning, Bapak. Good morning, Dr. Sentot.
Okay, good morning.
Yeah, Dr. Sentot. So we already have a presentation from Mr. Sandip, and now I would like to invite you to also present your topic. Of course, it's still about COVID-19 for today. Dr. Sentot will present the topic with the title Neighbor Communication Acceleration to Decrease Leveling Status in Pandemic. But before Dr. Sentot presented his presentation, let's see the curriculum vitae of Dr. Sentot. So Dr. Sentot have a very amazing experience, especially as a leader from hospital. Dr. Sandip. So Dr. Sentot, before Dr. Sentot joining in our campus, Dr. Sentot is he has a lot of experience, especially in clinical or hospital. Dr. Sentot used to as a director of public hospital in Kediri City. And then he is also the leader of Dinas Kesehatan, like a government state for health in our city. And right now he is in charge to be a rector in our campus. Okay. Before we start our presentation, I would like to say hi to Dr. Sentot. Dr. Sentot, good morning. Would you like to say hi to all our participants and also Dr. Sandip?
Hi. Good morning, my friend, Mr. Sandip, Professor Sandip. Good morning. It's okay. Associate Professor Nelrimon, Dr. Tangko Titus, Dr. Nita Madap, and Honorable my friend from District Madiun is Mr. Jainal Bidin. Good morning, and I hope it's healthy. Maybe I want to set my stories, ladies and gentlemen. Like this in my condition with Mr. Professor Sandip, I get the problem, the topic from this local or community, local community. It's like in Indonesia, RT. Yeah. Neighbor communication is like this RT, rukun tetangga.
Or neighborhood.
Yeah.
So it's like small community in a village.
It's small.
We call it RT.
RT.
In Indonesia, or rukun tetangga.
Okay, ladies and gentlemen, starting case COVID-19 in Indonesia in Monday, the day 2nd of March 2020, starting of COVID-19, increased cases to outbreak on July, August 2020. Okay. Divided of the COVID in Indonesia, the first year in 2020, second year in 21, maybe more in third years, maybe to decrease or zero green soon. Big cases COVID-19 pandemic in 21 June 31. From our in data today, the cases in Indonesia 4,24 million is positive confirmed, and 143,000 it's died by COVID-19 outbreak. We hope that just year from starting March 2020, the cases is to decrease. Like this in east of Java, first leveling in the city 4 among 38 districts. Okay, and now the strategy of the activity in Indonesia is like this PPKM. Emergency public activity restriction is PPKM must get the word protocol. Wearing a mask, washing hands, and social distancing. If the head protocol, 5 health protocol, plus stay away from the crowd and restrict to mobility. Leveling indicator is interaction, community, and ventilation. Ventilation, we brought not close, and decrease of leveling from fourth to first leveling with PPKM. It was not an easy choice for the government, as it also means forcing the community to reduce their activities outside the home, restricting to enforce social distancing, and all types of activities will be reduced. And what the effect to public? Okay, next. No. Before. Okay. Before. Okay, before. Okay, what's the effect of the public? Restricting in large region is not successful, unsuccessful. The government tried to manage strategy with the public together. Like, okay, it's right. This before. Next. Okay. Nah. What's the effect to public and economic? The government tried to manage strategy, make the public together. First year with PSBB, pembatasan sosial berskala besar, all social restriction large scale, unsuccessful. Second year with PPKM, memperlakukan pembatasan kegiatan masyarakat. The part one is not successful. And PPKM darurat. Together we obey PSBB to PPKM darurat. The government avoid lockdown area. However, the burden lockdown effect was borne disproportionality by the poor family. What happened? The governance of cases. Testing who's the case, tracing the case, treatment independent, isoman, like this Indonesia isoman, isolasi mandiri, isolation or in hospital. And this final step is vaccination in 3 groups, adult, geriatric, and prepare to kids 6 to 11 years. Restriction statistic in PPKM, priority to poor family, social acceleration in social funding by BLT, bantuan langsung tunai, cases of the many, PKH from not and must be to synchronize. The problem is not synchronized and not coordination, and must be to synchronize the program in local area. Data collection for family especially, yeah, exposed to COVID. Next. and the village strategy on fourth level by PPKM, like this in before, acceleration with share, DLT, and Dana Desa, monitoring evaluasi with KPM, synchronization subsidy from APBD, budgeting local district or government, and priority the dating data collection for family, especially family infection by neighbor community. And now I want to talk about leveling. Leveling to area or zona must be to vaccination, and green or leveling, first leveling, not cases. Yellow or second leveling is low transmission, around 1 to 5 family infection among 2 days. Suspect cases and strict lockdown. Strict lockdown in local community. And leveling orange, such leveling, transmission is middle. Yellow, 9 to 10 family suspect disease, lockdown, and the priority is close priority facility, playing ground, public space. Okay, it's close like this. And red zone, high level transmission, up of 10 hosts, which family and PPKM, RT, PPKM darurat, tracing, lockdown, public space close, stopping mobility before 8 p.m. and nothing party. This is perkembangan bor rumah sakit in Indonesia on PPKM 4th level. And now the level of East Jawa Timur, like this, 34, and it's level 1. And this picture, during the outbreak June, July 2020 and 2021, like this. Indonesia, salib India, Brasil, kematian baru COVID, Republik Indonesia tertinggi di dunia. And now in 21, October 21, 34 district in East Java, now in level 1 Kemenkes version, head department, and 32 district in East Java with Kementerian Dalam Negeri. The result of PPKM, majority districts in East Java on first level. And now the new Happy New, not Happy New Year, happy to public in East Java, in Indonesia, Center Disease Control and Prevention or CDC in USA to declare Indonesia entered the green zone. CDC USA, Indonesia masuk zona hijau COVID-19. And this is leveling by head department in Kemenkes confirmed case, inpatient pasien dirawat, mortality, testing, and tracing and treatment. In Mendagri, the legal of Mendagri is 70 public vaccination and 60 vaccination in pediatric. And what about the successful to decrease in East Java? It's a local wisdom enabled community whose the leader is the local public figure. Local wisdom by public figure like this Yai, clergyman, and from army, Babinsa. And for police is a Babin Captain Fitness. And in head of Bidan Desa community by village. And the best of successfully adalah Pak RT. Nah, this is local wisdom enabled community. The local Babinsa, Babin Kamtipmas, and Bidan Desa. We must to treat COVID-19 and its trend going on. Thanks with the change, talk about role to decrease COVID in local must become a priority in health community. Thank you for listening to my speech. I hope one stay healthy. Everyone stay healthy. I'm sorry. I hope everyone stay healthy and the pandemic COVID-19 can end sooner. Thank you. Good morning. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Okay, thank you for a very nice presentation, Dr. Sentot, about neighborhood awareness, especially to deal or help decreasing the number of COVID-19 around us. Thank you for the information, Doctor, and maybe I will have a few questions about neighborhood communication after this. Yeah. Okay. Now we will continue our session with discussion and answer with all the participants. I already seen the chat. Some chat already replied by Dr. Sandip. Thank you very much for the answer, Doctor. But maybe I have a few questions. The first is for Dr. Sandip. Okay, Dr. Sandip, especially I still have, I still curious with a phenomena in my country. But maybe do you have a perspective or maybe do you have opinion to help us, enlighten us how to deal with this? Right now, almost half of Indonesian people already vaccinated, and some of them are already get euphoria, or maybe they are too excited, and they have a new opinion right now. It's happened around me, so they always say that after I got the second vaccinated, I will be immortal. Or maybe I will, yeah, I have a full immune to deal with COVID, so I don't care anymore. Not only I'm not afraid, but I don't care about COVID. So sometimes they don't want to wear a mask, or maybe already forgot how to wash their hand because they say that I'm fully vaccinated. I have 2 certificate vaccination. So how you will deal with this kind of low self-awareness, especially in public or like a citizen, when they have no basic knowledge about health, we know, like people in the market, traditional market especially, if they already got vaccinated, then I am free from COVID-19. So how can we deal with any kind of stigma, that kind of stigma, new stigma right now, especially around me, because I'm living in a rural, so it is in a rural city. We still have a lot of traditional community, like market, and then like neighbor around us, and this is what happened now. So I am free because I am fully vaccinated. How to deal with that? First, I would like to ask Dr. Sandip opinion, and then the next I would like to ask a suggestion from Dr. Sentot. How can I deal with my community with that kind of stigma?
Okay. Thank you, Mr. Sandip.
I explain, sir?
First, maybe from Dr. Sandip.
Yes. Okay, sir. Just as you told that after vaccination also, we can see that COVID can infect. And vaccination is giving the protection of efficacy around 70%, 80% like that. It is not that 100% it will protect for the infection. So after vaccination also, the COVID can infect, but the severity of the infection is less. So if I have 2 vaccines, I may be affected again. So that thing we have to inform to the society again and again, like we are informing, we have to make hand wash, we have to wear mask, we have to wash hand, we have to make social distancing, etc. Same way, we have to again and again aware the people. But as we seen from our experience, and we can see whole world, the human behavior, that we are not maintaining our distance. Whenever the restaurant open, we go out with friends and make gathering. So that is the main thing. And of course, you can see the Singapore, the cases increase. Why? Because the Singapore, they use the public transport. And that is the main another cause, because it is not that they are not vaccinated and they are not means maintaining distance, etc. But as they using private transport, the cases increase. It is one of the reasons. So like that, we have to, it is that not so much stigma, that is we have to aware, and it is means not stigma actually, it is coming on the way, we can tell. And I think Dr. Sentot also maybe want to tell something, sir.
Okay, from Dr. Sentot, bagaimana ya dokter, saya kan nakes juga ya di lingkungan saya, tapi kadang-kadang suka gemes gitu loh. Pasti yang diandalkan adalah sudah full vaksin, anything like that. So, okay, datang bertamu ke rumah saya di depan. I already prepare like water and then hand wash, but they just passing it, and like that sometimes as an Indonesian people with okay, you come to my house, but you miss the disinfected, the spray or the hand wash. Okay, I cannot say anything because they are my neighbors. So how to deal with that? Bagaimana ini dokter saya menjelaskan ke teman-teman ini loh. Itu sudah tak kasih air tapi tetap udah mbak, saya sudah vaksin. Biasanya senjatanya kayak gitu. Mohon pencerahannya ini dokter.
I think sad network problem.
Oh yeah, I think we are losing. Okay, or maybe I will continue with the next question from our participant. Oh, we have a question here from Mbak Winda, from Miss Winda. So Miss Winda, She has a question for you, Dr. Sandip. Dr. Sandip said that when people get infected by the coronavirus, they will get bad stigma from society. Imagine that we were one that infected with that COVID-19. What can we do to overcome that stigma?
This one, there is a stigma from the community that come from we said that currently all kinds of diseases are always associated with COVID. Yes, this is a means previously it was high, means any patient come, the hospital health workers they think that it is associated, means they bring COVID also. Like the pregnant woman come for delivery, the person, worker and the health staff, they thought that it may be COVID because the test facility is not so high, and it immediately the mother give birth, and mother was instructed to clean the placenta and everything by herself, and baby were to wash by herself. It is not possible, and after giving birth the mother died. So this thing happened. But now actually what happening, if the vaccination is there, we can see that he has double vaccine. So we are now the health workers already know that, are aware that yes, it is a means not affected with COVID, means chance is less. And of course they are tested always when they go for hospital. They have to test first day, and after evening get result, then only they admitted to other cases like operation or anything. So if anybody affected with gallbladder, suppose example, the hospital will take admission first and they will test, and evening only they will shift to the normal ward. They will keep in isolation ward, and then evening they will shift in the, after getting the result, they will shift to operation, means for the operational procedures. It is not that directly they will take admission for operation, because it will arise other complication if the patient is affected with COVID. It is not that it may not affect, means the disease is conjoined with other disease. It is comorbid factor may be affected also. So this thing we have to, means the health workers already know. Community level the people is not aware, and it is very difficult to aware them.
Okay. Thank you for the answer, Doctor. Now we have Dr. Sentat here.
Okay,
Dr. Sentat.
I'm sorry. My communication is
network problem.
Okay, yeah. Maybe like this, Mr. Professor Sandi. In Indonesia, stigma it's scared and disturbing, creepy and disturbing. Creepy and disturbing. Why? Every 10 minutes, every 14 minutes or 30 minutes, the siren of ambulance is voice. What happened? Someone to die. In June and July 2020 and August 2021. Why? The cases on July, August, and 2020 is a stigma in war and family and education in traditional market to close when we want to decrease the cases, but in Indonesia, in Japanese, it's pakebluk, like this, maybe fever in the morning, maybe in the evening is die. And it's a problem, it's a condition like this. My friend, Professor Dr. Sandu, died by COVID-19. But it's my stigma, it's my situation, scary situation. Then we hope the third year from starting March 2020, the crisis is decreased, the cases is decreased, but we prepare in around in New Year, the end of the year, in December of the starting of the year, in January, we must to prepare and maybe government to lockdown like this PPKM. Now PPKM darurat is to opening, yeah, and we maybe in now in Indonesia prior to hybrid education, partially maybe 30–40% of offline, and this maybe for the 60–70% is online. It's maybe stigma about pandemic, COVID-19 pandemic is gone. Maybe it's okay with protocol, health protocol, and to coming the new normal. We must wear mask, and the to distance, and it's okay like this. 3 or 4 or 5 is to decrease cases. Yes. Okay. To acceleration is we want stigma about COVID-19 is gone. Maybe my answer to Mr. Sandeep and my friend, we hope in Indonesia is all Indonesia is first referring or green zero, and what's the public figure is Pak RT. Yeah, it's okay.
Okay, thank you, Dr. Sentat, for a very relieving answer. So Pak RT is our hero now. Not our hero, our keeper ya, lebih ke penjaga, our keeper in our neighborhood. Okay, okay, okay. Maybe I have a question from. Oh no, I think Dr. Sandeep already answered some of your question in our chat. This is from myself, Dr. Sandeep. For about apps in Malaysia, you are using My Sejahtera, if I'm not mistaken, as your app. Yeah, it's
like this.
It's now, yeah,
like this. But LT in Indonesia.
Yeah. Okay.
But LT is money contact.
Okay. Okay. Yeah. So for your app for My Sejahtera in Malaysia, it is including vaccine certificate or vaccine vaccine time, and then how many times you check in a view place, or how many times you are testing by COVID test or anything like that. Oh yeah. Do you have any rejection from your citizen maybe? How about if my parent already old, but they want to go to the bank sometimes they cannot use that app because they don't know how to use a cell phone or anything like that. How to deal with that kind of problem? Because I saw maybe it is still new in Indonesia. It is for about 2 months. We are using this kind of app, and it is still, and there are still a lot of problem by using this app. And sometimes people can go to one place if they are showing an ID. So some people using an ID, make our own ID that we are already vaccinated to replacing the app, because sometimes our person is very old or elderly, so they don't know how to use a phone cell or app in phone cell. How to deal with that? Is it any kind of problem in Malaysia? And do you have any policy to deal with that kind of problem?
No, actually in Malaysia they issue the hard copy card also, vaccination card. So they can carry. And but as duplicate of card can be made, so Malaysian government focuses on software that duplicacy cannot be made, because card anybody can photostat and can change. So that means they don't want. So for that they focus on app. And I see that in bank many old person come, the security person help them to register in QMS like that. Not that and also if you see the MySejahtera app, you can see that there is a option of dependent and etc. So we can add the dependent vaccination, and in that the parents and their certificate will come digitally. So if the parents aged person is going, so we have to accompany them, because alone cannot go in this pandemic time, and of course we have to take care of them. So like that we have to take care, and accordingly we have to help them. So it is not that only app is there, and of course there are many places they are using the note also. If they don't have cell phone in very poor area, like rural area, they use the note that this time you are entering and this is the temperature and IC number, like that they note and enter in the shop.
Okay. But we still have to make a note where we can go, or maybe any kind of place that we already visit, something like that.
Yes, because everybody don't have the cell phone, everybody may not have the network, etc. Many problems are there. Not that 90% of people have the network and etc. Nobody have so much money to buy a cell phone with the apps, etc. So they are moderating, of course, they allow, and like that we are moving. Let us see how many problems are there.
Okay, so it's almost the same in Indonesia.
Yes.
Yeah. Okay. And then for the last, maybe I have a question for Dr. Sentot.
Yes.
About the rule of Pak RT, still Pak RT. Yeah. We know that some people in our country concerned not about their health, but maybe about their economic condition.
Yes.
Especially in neighborhoods. So sometimes people don't care if I get infected with COVID-19 or not, but how about my economic, if I still live with the policy from the government that we cannot go there, or we need to make pembatasan ya, PSBB tadi ya. Nah, how about the rule of Pak RT to help the people? Because like Dr. Sentot say that BLT or like BLT coming also from Pak RT.
Yeah. Yes, about Pak RT, local wisdom in Indonesia, in like this in village, the small in community in a village in Indonesia, there's rukun tetangga. Rukun tetangga is like this neighbor community, and in neighbor community supervision by Babinsa from army, Babinkam Fitness from police, and the
from military that help Pak RT.
No, and Bidan Desa.
Oh, from the midwife.
Yeah.
That have a job in the village.
There are collaboration with Pak RT. Pak RT is a leader of the minor neighbor community, and we dating from the family in this area, local area, how many family is to every local, every of community, Mr. on Mrs. RT to supervisi and data collecting about the family, the everyone, and warga. Mungkin warga seperti ada yang di Malaysia. Jadi it's collecting maybe someone infection by COVID and close restriction of close the area with supervision army, police, and the bidan desa of the village. Maybe it's enough. Yeah.
Okay, thank you for the answer, Dr. Sentot. Yeah. Okay, I think that's enough for today. No more question from the chat box. Okay, from our presentation about these two topics from Dr. Sandip, we have the topic about stigma in COVID-19 that will lead us to change, to give a new behavioral change in our life. Actually, disease is still disease no matter where it comes, and people should adapt it with it, no matter how hard it is and how hard to make a change in our behavior. Yeah. And then from Dr. Sentot, I get the new opinion that actually neighbor, if we want to learn something or if we want to create something, we can start from our neighborhood first. If we can communicate well with our neighborhood, it will also help us dealing with problems. That's all from our presentation. Once again, I would like to say thank you very much from our both speaker. It is give us a new perspective about this COVID-19 from the biggest one until the smallest part in our community. Okay. Once again, thank you so much, Dr. Sandip and Dr. Sentot, for joining in our conference. And before we close our session for today, maybe I would like to share the certificate as this is as thank you from our committee, IT department. Please share the certificate for Dr. Sandip and Dr. Sentot.
Okay, thank you, Mr. Sandip.
Okay.
When you going to Kediri, Mr. Sandip?
Yes, sir.
Mr. Sandip, would you like to come to Kediri?
Yes.
East Java.
Of course.
Yeah, one day after the government releasing a new policy about traveling, I guess we can. I guess you can visit our city.
Yes, my pleasure. Thank you for the invitation.
We're waiting for you, Mr. Sandip.
Okay. Okay. So this is the certificate from our conference. The first is for Dr. Sandip. Thank you very much for joining us as keynote speaker. And the second, this is the certificate. This is verified to Dr. Sentot Imam. Thank you so much, Doctor, for giving your time as a keynote speaker in our conference for today. Okay. From our session, we already finished this session, and before we close the session, I would like to I'd like to thank you so much for the speaker for informative and interesting presentation. And hopefully this topic will give us a benefit for everyone. Please give applause for our speaker for today. And once again, thank you. As a moderator, I would like to say, I would like to apologize if there are any mistake while taking this event. Let's close the session together. Good morning and wassalamualaikum warahmatullahi wabarakatuh.
Thank you. Stay safe, everybody.
Thank you so much, Dr. Sandip. Thank you so much, Dr. Senton.
Thank you.
Okay, I would like to give it back the time to the Master of Ceremony. Thank you for the time, Master of Ceremony.
Ya, kita ya. Oh.
Ladies and gentlemen, thank you very much to Professor Dr. Sandip Podar and Dr. Sentot Imam Suprapto for the very fantastic and informative presentation. Well, ladies and gentlemen and all happy participants, before we go to the next symposium, I would like to inform you that we will have about 30-minute breaks. Ladies and gentlemen, please come back 30 minutes later. Thank you and have a nice lunch.
Inilah Indonesia, keanekaragaman budaya dari berbagai daerah berkumpul menjadi satu kesatuan menciptakan generasi muda yang aktif dalam dunia kesehatan. Karena jiwa yang sehat akan menciptakan bangsa yang kuat. Institut Ilmu Kesehatan Strada Indonesia, kampus kesehatan yang berada di Kota Kediri, memanggil kaum muda Nusantara untuk sadar akan ilmu kesehatan. Terakreditasi B, memiliki berbagai program unggulan, menunjang branding internasional, dengan pemberdayaan dosen yang profesional di bidang kesehatan. Maka terciptalah mahasiswa yang kompeten. Branding 4G memaknai kampus dengan mendukung program kampus Merdeka Belajar, Good Competen, Good English, Good Personality and Mentality, Good Placement of Preparation akan membawa lulusan kampus kesehatan Strada mampu bersaing di tingkat internasional. Memiliki 12 prodi dengan jenjang vokasi, sarjana, profesi, dan pasca sarjana, dibentuk menjadi 3 fakultas dengan atmosfer belajar yang nyaman, pelayanan yang ramah, serta lingkungan yang asri, mendukung berlangsungnya perkuliahan yang kondusif. Tak lupa dengan modul online, efektivitas pembelajaran pun tercipta. Inilah kampus mahasiswa seluruh Nusantara menjadi satu kesatuan. IIK Strada Indonesia mencetak generasi milenial berbasis kesehatan. Brighter Future, English and Digitalisasi, Kampus Strada Indonesia.
upon the heaven is thanking just for you. And Mr. Moon, he came by to say good night to you. I'll sing for you, I'll sing for Mother, we're praying for the world. And for the people everywhere, when I saw them all, we can. Oh, my sleeping child, the world's so wild, but you read you home. Paradise, that's one reason why I'll cover you, sleeping child. If all the people around the world, they had a mind like yours, we have no fighting and no wars, there'll be lasting peace on earth. If all the king and all the leader can't see you heard this way, they will hold the earth in their arms, they will learn to watch you play. Oh, my sleeping child, the world's so wild, but you read you home. Paradise, that's one reason why I'll cover you, sleeping child. I'm gonna cover my sleeping child. Keep you away from the world so wide. Keep you away from the world, away from the world so wide. Oh, my sleeping child, the world's so wild, but you read you home. Paradise, that's one reason why I'll cover you, sleeping child. Oh, my sleeping child, the world's so wild, but you read you home. Paradise, that's one reason why I'll cover you, sleeping child. For our children, for the world we live in, for our children. There's a place in your heart, and I know that it is love. And this place go much brighter than tomorrow. And if you really try, you'll find there's no need to cry. In this place, you'll feel there's no heart or sorrow. There are ways to get there if you care enough for the living. Make a little space, make a better place. Heal the world, make it a better place for you and for me and the entire human race. There are people dying. If you care enough for the living, make a better place for you and for me. If you want to know why, there's a love that cannot lie. Love is strong, the only grace of joyful giving.
is bliss we cannot feel. Fear of dream, we stop existing and start living. That it feels that always love's not for us growing. So make a better world, make a better world. Heal the world, make it a better place for you and for me and the entire human race. There are people dying. If you care enough for the living, make a better place for you and for me. And the dream we were conceiving will reveal a joyful face, and the world we once believed in will shine again in grace. Then why do we keep strangling life when this heart could save this soul? There is plain to see this world is heavenly. Be God's glory. We could fly so high, let our spirit never die. In my heart, I feel you are all my brothers. Create a world with no fear. Together we cry happy tears. See the nation turn their sword into plowshares. We come really get there. If you care enough for the living, make a little space to make a better place. Heal the world, make it a better place for you and for me and the entire human race. There are people dying. If you care enough for the living, make a better place for you and for me. Heal the world, make it a better place for you and for me and the entire human race. There are people dying. If you get enough for the living, make a better place for you and for me. There are people dying. If you care enough for the living, make a better place for you and for me. There are people dying. If you care enough for the living, make a better place for you and for me. You and for me, a better place. You and for me, a better place. You and for me, a better place. You and for me, the world will live in. You and for me, save it for our children. You and for me, the world will live in. You and for me, save it for our children. You and for me, the world will live in. You and for me, save it for our children. You and for me, the world will live in. You and for me, save it for our children.
Ku terima suratmu, telah ku baca dan aku mengerti betapa merindunya dirimu akan hadirnya diriku di dalam hari-harimu bersama lagi.
Kau bertanya padaku, kapan aku akan kembali lagi. Katamu kau tak kuasa melawan gejolak di dalam dada
tertulis dalam suratmu. Kau katakan padaku, saat ini ku ingin hangat pelukmu dan belai lembut kasihmu, takkan ku lupa selamanya. Saat bersama dirimu, semua kata rindumu semakin membuatku tak berdaya.
kuatkan hati dari kamu yang belum juga kembali. Ada satu keyakinan yang membuatku bertahan. Penantian ini kan terbayar pasti. Lihat aku sayang yang sudah berjuang menunggumu datang, menjemputmu pulang hingga selalu sayang. Hatiku kau genggam, aku takkan pergi menunggu kamu di sini.
Bukan kepadamu, aku tidak tahu lagi.
Pada siapa rindu ini kan ku beri. Pada siapa rindu ini kan ku beri. Lihat aku sayang yang sudah berjuang menunggu datang, menjemputmu pulang hingga selalu sayang. Hatiku kau genggam, aku takkan pergi menunggu kamu di sini. Lihat aku sayang yang sudah berjuang menunggumu datang, menjemputmu pulang. Lihat aku sayang yang sudah berjuang menunggumu datang, menjemputmu pulang hingga selalu sayang. Hatiku kau genggam, aku takkan pergi. Oh, aku takkan pergi menunggu kamu di sini.
Ku terima suratmu, telah ku baca dan aku mengerti betapa merindunya dirimu akan hadirnya diriku di dalam hari-harimu bersama lagi. Kau bertanya padaku kapan aku akan kembali lagi. Katamu kau tak kuasa melawan gejolak di dalam dada yang membara menahan rasa pertemuan kita nanti. tertulis dalam suratmu. Kau katakan padaku, saat ini ku ingin hangat pelukmu dan belai lembut kasihmu, takkan ku lupa selamanya. Saat bersama dirimu, semua kata rindumu semakin membuatku tak berdaya menahan rasa ingin jumpa. Percayalah padaku, aku pun rindu kamu. Ku akan pulang melepas semua kerinduan yang terpendam. Jangan katakan cinta namun jauh di sana. Sayupku dengar melodi cinta yang menggema, terasa kembali gelora jiwa mudaku, karena tersentuh alunan lagu sembadu kopi dangdut. Api asmara yang dahulu pernah membara, semakin hangat bagai ciuman yang pertama. Detak jantungku seakan ikut irama, karena terlena oleh pesona alunan kopi dangdut. Irama kopi dangdut yang ceria menyengat hati menjadi gairah, membuat aku lupa akan cintaku yang telah lalu.
Api asmara yang dahulu pernah membara, semakin hangat bagai ciuman yang pertama. Detak jantungku seakan ikut irama, karena terlena oleh pesona alunan kopi dangdut.
Jantungku, ser-ser-ser bunyi darahku. Dakdikduk dengan jantungku, ser-ser-ser bunyi darahku. Nah, mengapa kamu datang lagi menggodaku? Dulu hatiku membeku bagaikan segumpal salju. Ku tak mau peduli, biar hitam biar putih, melangkah berhati-hati, asal jangan nyebut kekali. Api asmara yang dahulu pernah membara, semakin hangat bagai ciuman yang pertama. Detak jantungku seakan ikut irama, karena terlena oleh pesona alunan kopi dangdut. Irama kopi dangdut yang ceria menyengat hati menjadi gairah, membuat aku lupa akan cintaku yang telah lalu. Kala ku pandang kelip bintang jauh di sana, sayupku dengar melodi cinta yang menggema, terasa kembali gelora jiwa mudaku, karena tersentuh alunan lagu sembadu kopi dangdut. Api asmara yang dahulu pernah membara, semakin hangat bagai ciuman yang pertama. Detak jantungku seakan ikut irama, karena terlena oleh pesona alunan kopi dangdut. Karena terlena oleh pesona alunan kopi dangdut. Karena terlena oleh pesona alunan kopi dangdut.
Inilah Indonesia, keanekaragaman budaya dari berbagai daerah berkumpul menjadi satu kesatuan menciptakan generasi muda yang aktif dalam dunia kesehatan. Karena jiwa yang sehat akan menciptakan bangsa yang kuat. Institut Ilmu Kesehatan Strada Indonesia, kampus kesehatan yang berada di Kota Kediri, memanggil kaum muda Nusantara untuk sadar akan ilmu kesehatan. Terakreditasi B, memiliki berbagai program unggulan, menunjang branding internasional dengan pemberdayaan dosen yang profesional di bidang kesehatan. Maka terciptalah mahasiswa yang kompeten. Branding 4G memaknai kampus dengan mendukung program kampus Merdeka Belajar, Good Competen, Good English, Good Personality and Mentality, Good Placement of Preparation akan membawa lulusan kampus kesehatan Strada mampu bersaing di tingkat internasional. Memiliki 12 prodi dengan jenjang vokasi, sarjana, profesi, dan pasca sarjana, dibentuk menjadi 3 fakultas dengan atmosfer belajar yang nyaman, pelayanan yang ramah, serta lingkungan yang asri mendukung berlangsungnya perkuliahan yang kondusif. Tak lupa dengan modul online, efektivitas pembelajaran pun tercipta. Inilah kampus mahasiswa seluruh Nusantara menjadi satu kesatuan. IIK Strada Indonesia mencetak generasi milenial berbasis kesehatan. Brighter Future, English and Digitalisasi, Kampus Strada Indonesia.
Mimpi adalah kunci untuk kita menaklukkan dunia. Berlarilah tanpa lelah sampai engkau meraihnya. Laskar
Hello?
Yes.
Okay. Slide. I'm sorry, the slide is
not working.
In the slide. I'm sorry, the slide is not.
It's not working well. Okay,
yeah,
you can
yes.
re-upload.
Okay.
Okay, you can slideshow now. Yes, please.
Yes, okay. Saya lanjutkan, okay. In the first about information of COVID-19. The information that we can examine regard COVID-19 is quite easily to get. This information can be assessed independently of the public. So it's proper for the public to be able to read, learn in them of prepare for the risk caused by COVID-19, aspect readiness of view of the new normal in the context of the endemicity of COVID-19. It's more than 2 years ago, and 64 countries affected countries have felt it. Okay, and then epidemiology of COVID-19. COVID-19 is a communicable disease and human-to-human transmission. Ya, semua mengetahui bahwa COVID-19 merupakan pandemi yang sedang berlangsung sampai saat ini. And then the regarding to the new normal, it is hoped that the public will know about health condition and in their area and role of new normal during the COVID-19 pandemic, to mental trend in danger or effect of the COVID-19 pandemic. All the opportunities, the challenge, so that the community able to sustainable life. Yeah. In the second about description of epidemiology, COVID-19 is related to the inside the condition. This is parent the COVID-19 that entered Indonesia since March 2020 has a significant impact in economic life of Indonesia and other affected countries. The process of transmission that occurs from human to human and through several media show that the spread of COVID-19 was initially very fast and uncontrolled. It can be seen in the table that the number of COVID-19 is 9.4% in East Java and Madiun 1.8% in East Java. While the recovery rate is high 19% with no less than 7.5%, that effort to prevent it through accelerating target of the first dose vaccination in the achievement. National currently is 57.6%. East Java 62.1%, and especially Madiun has reached 98.1%. This is good capital to achieve community immunity, even though the second dose has not reached 15%. Okay, and then in the third part, prevention and control of COVID-19 in effort to prepare for the endemic period later. This submission is started by Dr. Sentot Imam Suprapto, Rector of IIK Strada Kediri, that the safe of health restriction and protocol are carried out as a form of effort to prevent the spread of COVID-19 massively. The government of Indonesia is enforced large-scale social restriction. In Indonesia, pembatasan sosial berskala besar, or PSBB, to respond to the state of emergency in public health. The government has implementation transitional PSBB in some red zone area, despite the surge in the case number. Alternatively, the government is enforcing large-scale social restriction in micro, the example RT. Lack of education, socialization, where the number remain massive. Even though we know that being done is the health protocol 3M, are washing hand frequently, wearing a mask when interacting, and social distance 1 until 2 meters from each other. That turned out that all of them have not been able to answer all the challenges in suppressing distribution. In our country, this health protocol is known as 5M. Already know that the 5M health protocol are to help prevent the transmission of the coronavirus. The following is the 5M health protocol. Number 1, hand wash. Washing hand regularly is one of the most effective health protocol to prevent transmission of the coronavirus. From maximum result, it is recommended that you wash your hand for at least 20 seconds several times a day, especially when before cooking or eating, after using the bedroom, after shake hand with other people, after covering the nose when coughing or sneezing, and after walk outside. Washing hand using soap and suppress transmission by up to 17%. And then number 2 is keep your distance. No. Wearing a mask, using mask in one has health protocol have to, because it protect from COVID-19 virus, especially in the environment. Research says the using a mask by means of is able to filter particle released by someone up to 85.4% if KN95 77%. And then stay from the crowded. In addition to the 3 things above, staying away from crowded is a health protocol, as must also be done. According to the Indonesia Ministry of Health, people are asked to stay away from crowd when outside their homes. Remember, the more and often you meet people, the higher the chance of getting infected with the coronavirus. Therefore, avoid crowded places, especially if you are rich or over 16 years old. Physical distancing, according to research, the elderly and people with chronic disease have a higher risk of contracting the coronavirus. If you often meet the older people and talking, physical distancing, maintaining distance consistently and collectively can reduce the risk of transmission by up to 85%. Number 5 is reduce mobility or interaction. The virus that causes corona can be anywhere, so the more time you spend outdoor, the higher your exposure to this nasty virus will be. Therefore, if there is no urgent need, stay at home. According to the Ministry of Health, even though you are healthy and there are no symptoms of illness, it doesn't mean that you will return home with some condition, because the coronavirus can spread and infect someone quickly. Reduce the mobility is really important, which is not going around except the emergency condition. So until now, as we can do is online system on work or study. So its government do for limits the social walking. For first reduce the case, and we have stay Indonesia economic development. But from the beginning of PPKM, emergency PPKM until PPKM with 4, 3, 2, 1 level indicate positive result. A study that the positive confirm of number and additional case the per day for the last 4 months since PPKM look evening Java and Bali, affecting Java and Bali. In the cumulative case in Indonesia, in the blue line is confirmed number continually rising shall be the number of cases. The hope is the graph below blue line, and blue line standard number in the transmission to endemicity. So with numbering average condition additional of case per day that some facts significant hope is like the blue underline. The probability of case is 3.3%. So the cumulative case confirmation of 30.5%. This probability in cumulative case July until October in Indonesia. This is additional case per day. Additional case per day. The probability 3.3% if you not discipline of health protocol. And then in Madiun, the same. So it's some condition in Madiun. Trend can be occur both nationally and district or city in the threat is a probability of an increase in case if the community is tooth-free in activities and undisciplined in application health protocol 5M in above, case increase cumulative, sharing with the average probability of additional case per day as much as 16.9%. That's the explanation that conveyed. The essence is the existence of fundamental challenge in adaptation to the new normal life in the endemicity of COVID-19, that the health protocol is the key to preventing the spread of COVID-19. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Mr. Zainal, for your such informative and interesting presentation. Okay, and now we will continue to the second speaker. We have Dr. Nurwijayanti, MKes from IIK Strada Indonesia. Before that, we want you to know Dr. Nurwijayanti will deliver the topic strategies for improving nutritional status of children under 5 communities. And here for the curriculum vitae of Nurwijayanti. Okay, thank you. And please, for operator to show the curriculum vitae of Dr. Nurwijayanti. Wait a moment, because the operator will show the curriculum vitae of Dr. Nurwijayanti. Okay, because we have obstacle to show the curriculum of Dr. Nurwijayanti, we continue the agenda. Now, welcome the Excellency Dr. Nurwijayanti to deliver her presentation. Please, you may have time. Are you ready? Dr. Nurwijayanti, can you hear me?
Okay. Can you hear my voice?
Yes, okay. Yeah, okay, please take your time.
Okay, thank you for the time. I'm very happy and I'm very proud that I can attend in this forum. The Honorable Rector IIK Strada Indonesia, the Honorable all the speaker in this forum and moderator, the Honorable all audience, and thank you for the committee. To shorten the time, I will directly show you my presentation. The title of my presentation is Strategy for Improving Nutrition Status of Children Under 5 in Community. Next. Nutrition is a major issue of the world population. Development of health in terms of nutrition is part of effort to develop human being as a whole. It is, among other, carried out a third child health as early as the child in the womb. Effort of health in improvement may assign the child to the womb until the first year of life, intend to mind their survival and improve their quality of life in order to achieve optimal growth and development. Physical, mental, emotional, and social, as well as having multiple intelligence in accord with the genetic potential. Even high morbidity and mental development are direct or indirect result of disrupts growth. Next. Nutrition problems in Indonesia are more prevalent in children under 5 years, despite the progress in overcome the problem of malnutrition in Indonesia over the past 10 years. Nutrition status of the community can be accessed on the basis of the nutrition status of children under 5. Malnutrition affects children's future growth in the childhood, the experience rapid growth and development, the recruit adequate supply of food and nutrition. Malnutrition in childhood may have physical, mental, social, and intelligence disrupt growth, which is permanent until the adulthood. More especially, malnutrition may causes retarded growth of the body and, more importantly, in brain development. Addition, it might decrease or lower the body resistance to infectious disease. The issue of undernutrition in children under 5 is caused by many direct and indirect factors. Look at the picture. Among the direct factors of malnutrition are inappropriate feeding partners. Below the nutrition adequacy rate resulting in lower energy and protein intake. In addition, the presence of infectious disease may cause children under 5 to lose their appetite, resulting in reduced intake of food and drink into the body. Next. Nutrition problems are public health issue that cannot be overcome merely with medical and health service approach. In addition to being a proof syndrome closely related to the problem of food security, the household level is related to the aspect of knowledge and behavioral support and of a healthy lifestyle. How to overcome the problem? One, choose the determinant strategy for improving nutrition status of children under 5 in community. Nutrition problems are affected by a complex interplay of various factors. At the household level, nutrition status is affected by the family ability to grow food in adequate quantity and quantity first. Parenting is affected by education and behavioral factor, and family health status, nutrition status of children under 5 would be worse when the mother has poor knowledge of menu composition, provision of complementary food, and distribution of food in the family. In low-income family, children may suffer since the family income is used for the many family members. The community adequate knowledge of nutrition food for children under 5 would increase the nutrition status of children under 5 and vice versa. Family structure may have an effect on morbidity or shock of infectious disease and malnutrition and health service utilization. The next, this is character. Based on respondent character, health of children under 5 years is 55.5%, were male, and rest were female 44.5%. Most of the mother of children under 5, 64%, were graduate of high school and only a fraction of them were graduate of primary school their person. Next. Okay, next. Directly result. Okay. Look at the picture. Okay, next. Okay. Next. Okay, result in a statistic test of the direct effect of knowledge on nutrition status showing inner weight coefficient of 0.17 with at the value of 3.05 then there was a significant direct effect knowledge on nutrition status. And then a test of direct effect of socioeconomic status on nutrition status showed in inner weight of coefficient 0.02 with a t-value. There was no significant direct effect of socioeconomic status on nutrition status. The test of direct the result. There was a significant direct effect of parenting on nutrition status. And then test of the effect health service on nutrition status is direct. And then malnutrition is a completed and interrelated program, direct and indirect cases of undernutrition in children. Other 5 play their roles, which are varied and different in each area. Infectious disease and lack of nutrition intake are the interrelated. Malnutrition children will have a decreased immune system being sustainable to infectious disease. Strategy for improving nutrition status of children under 5 in community. Nutrition problems are divided into macro and micronutrient problems. Macronutrient problems are mainly caused by a shortage or unbalance of energy and protein intake. Manifestation of macronutrient problem in children under 5 are marasmus, kwashiorkor, or the combined and future disrupt of growth and development of children. Improvement of the macronutrient problem is aimed at reduce the macronutrient problem. Next. It is mainly carried out by addressing the problem of lack of protein, energy, especially in the poor rural and urban area. Improving the family nutrition status, increase community participation, improving the quality of nutrition-related service about in community health center and posyandu, and increase consumption of energy and protein of malnourished children under 5. Strategy to overcome to macro. Nutrition problems are implemented by environment families in terms of health and nutrition community development in nutrition improvement of health personnel and direct subsidy. Result of Presensi that malnutrition was affected by various interrelated factors. However, it was directly affected by 3 factors: children not receiving sufficient nutrition food, children not receiving adequate nutrition care, and children possibly suffering from infectious disease. The first cases of malnutrition of the babies and children did not receive balanced and nutrition food. The best natural food for the baby is breast milk, and after 6 months of eggs, they should be give complementary food in the appropriate amount and quality. A good complementary food not only contain enough energy, protein, but also iron, vitamin A, folic acid, vitamin B, and another vitamin and mineral. Appropriate and good complementary food can be prepared at home. In family with a low level of education and knowledge, a child has to be satisfied with simple food, not meeting their nutrition need due to ignorance. The second of malnutrition as the children do not receive adequate nutrition care. Children who are cared for with affection by their own mother, especially those mothers who are educated, understand the improving of breastfeeding, the benefit of posyandu and cleanliness despite the poverty and healthy. The factor of material education had the effect on the quality of child care. On the contrary, some malnutrition children were turned out to be cared for by their grandparents or caregiver who were poor and uneducated. The third cause of the malnutrition have that children suffered from infectious disease. There was a mutual relationship between the incidence of infectious disease and malnutrition. Malnutrition children would have a decreased immunity, leading to vulnerability to infectious disease. On the other hand, children suffering from infectious disease would tend to suffer from malnutrition. In order to overcome nutrition problem based on the feeding of the present study strategic a development for improving nutrition status of children under 5 in the form of action plan for the family, community, and government. Last, in city, there were a higher number of children under 5 with a normal and overnutrition status and some with undernutrition status. However, the undernutrition case were not alarmed, but still recruitment attention since there was one severe malnutrition child. Factor affecting nutrition status of children consists of factor with direct effect consists of feeding partner and nutrition status, and factor with indirect effect, including knowledge, socio-economic status, parenting, food security, and health service. The factor with the greatest effect was feeding partners. Strategy to overcome nutrition problem of children under 5, the first, revitalizing the function of posyandu, improving the ability of personnel in management of malnutrition, directly talking nutrition problem in vulnerable group, and then realizing nutrition conscious family, third, nutrition promotion, and the last, building cross-sectoral cooperative and partnership with the private sector of business and the community for resource mobilization in order to increase the purchasing power of family to provide healthy and nutrient balanced food. This is my presentation. I hope all audience interest with my theme, and thank you. Time for me, I will back to moderator.
Thank you, Dr. Nur Wijayanti, for giving informative and interesting information for us. And now, before we come to the last speaker, we will remind you to all the participants, if you have questions to all the speakers, you can send to the chat box or by raise hand if you want to ask directly to all the speakers when we open the chat box or when the question and answer session. Okay, for the third speaker, we have Mr. Ali Sodik from IIK Strada Indonesia. His topic is multi-level health promotion, and I will let you know his curriculum vitae. Please, operator, to show the CV of Mr. Ali Sodik. Okay, Mr. Ali Sodik is from one of lecturer in IIK Strada Indonesia, and his work experience is director of DIB, and then the education is in Magister of Art from Gajah Mada University, and he have many publications and also many experience. Okay, and now allow me to welcome to the speaker, the Excellencies, Mr. Ali Sodik, to deliver the presentation. Please, you may have your time.
Okay. Hello, Ms. Santi.
Yes, Mr.
Okay.
Ali Sodik.
Thank you very much. Hello, everyone. It's nice time to me to meet you all. Especially thank you very much to Ms. Santi to give me time, the opportunity to join in this conference for this very nice with the presentation to me. From Ms. Santi have said to me many experience. Actually, I just have a little experience. Okay, it's not much as you said because I'm still was that one of the junior lecturer here, but because I get the opportunity, so willy-nilly I must present for this time. Okay, for the interesting time for the operator, can you help me to share my point? During was that for with the topic on this international conference is this moment. It's not proper to my okay, okay. Okay. With the theme for this international conference is living with COVID-19 endemic. Okay, the opportunities, threats, preparedness or adaptation. For this section, I take my opportunity with the opportunities. Because of why? So when the first time I was joined in this conference, listen from Miss Mona and also Miss Nita and also Professor Handip and each other, Mr. Zainal Abidin and Dr. Nur Wijayanti. I have one of things about change behavior to all not only in Indonesia, of course in the world. So I think the multi-level health promotion, I think it is a very useful to to give the more fresh about health promotion. Okay, next slide. Okay, ladies and gentlemen, before I continue to my speech, I open for this speech by the Ottawa Charter. As we know, for the Ottawa Charters have the 5 domains of health promotion action. Okay, now in health promotion department, I think Ottawa Charter is become foundation if we make make the new method or media in health promotion. As we know, there is five domain in Ottawa Charter. For the first is building healthy public policies, and then for the second, creating supportive environments, and then for the third, strengthening community action, and the fourth, developing personal skill, and then for the fifth, reorienting health services. From Ottawa Charter, right? Okay, for Ottawa Charter, I try to more concern with the point of 2, 3, and 4, with the my things was that multi-level health promotion, because of creating supportive environment is very, very important for this Ottawa chapter, because when the public policy on health, especially health built, but when the supporting environment is was that less, or strengthening community action is no, or developing a personal skill is no, I think that the public policy for health is nothing. For example, if we from Indonesian, okay, I think there's so many participants from Indonesia. As we know, for example, the program in Indonesia is like Germas, Germas. One of thing Germas adalah we eat fruit or vegetable, but as we know, when the public health department or health office department, Dinkes, make some agenda or some meeting for the serve snack is not fruit and vegetable, maybe some cake or the modern cake like this. So I think for the Ottawa Charter, another healthy public policies, we must make it is more better about supporting environment, strengthening community action, and development personal skill. And in this theory, in this model, multi-level health promotion has covered about that. How to make supporting environment, how to make a community action, how to develop personal skill. Okay, ladies and gentlemen, operator, please, next slide. Now, in MLHP framework, I just say MLHP, multi-level health promotion. Actually, it is some of concept is not new, but it is must be highlight, because of why I think I turn with the some of theory multi-level marketing. If everyone know about that multi-level marketing, it is very interesting. Was that strategic? Very interesting role of model, because one person have a duty to make other people was that more know everything about that, and then to understand about that. So the value will be sent to everyone. Look at for the picture. There is value, competence, policy, action, environment, and health. So everyone's is agreed that for our was that concentration, not only in public health but also in all health sector, that for the most goal of the action is health. How to increase was that public health quality or health quality. So when we have the value, and then for this value is become a policy, but if there is no competence, there is no action, there is no support of environment, how can we increase of healthy to everyone, to public health? So in multi-level health promotion frameworks, we will do everything. Start from value, and then from value, we mix a sum of policy. After that, we grow, we create, we increase about competence. After that, we do action. For optimally, for do action must be supported by environment. And then for the goal of this framework is healthy. I give sample. As we know, we know that cigarette is not good. Smoking is not good. It is value. Smoking is not good. Cigarette is not good. But if don't have any policy, so this value is nothing, because everyone know, but there is no action. So from this value that cigarette or smoke is that is not good, is dangerous for our health, so we make policy. After we have with that do advocacy, and then have with that release the policy. For example, KTR, kawasan tanpa rokok, no smoking area. When we have policy no smoking area, if there is no sum of action from the good competence from with that health person, it is nothing. But when the from with that health promotion interesting, and then do or increase the competence, it is better to be action. Okay, if we do the action is betterly, it is not perfectly if environment is not support. For example, public health promotion, promotor kesehatan, penyuluh kesehatan, health educator, or nursing, or doctor, or nutrition, or each other have good competence about to give health education, and then they do action. But if environment is not support, it's not enough. Who is the environment? Environment, so many things, so many. I think that not only with that health major, but also the public health. So everyone can support. So in multi-level health promotion framework, we cannot do ourselves, or do yourself, or do myself, but we do together. We do together. So the action is very, very need environmental support to increase of health. Okay, operator. Next. Okay, ladies and gentlemen, the owning of the animal's capacity of improved health, a safe life, a public health researcher or practitioner have worked on developing effective frameworks. So actually it's too many, but we must make it is highlight how to create, how to implementation, the optimization health promotion strategies. So many actually, but up to now still for the result is not good enough. Because of why we sometimes the only for the health promotion we only what's that do by researcher or practitioner. We don't ask, or we don't ask to environment. public participant or public supporting for this health promotion strategy. Okay, next slide. Okay, ladies and gentlemen, as we know, I think some of illustration for the action, for the implementation, for this theory, for this model that is multi-level health promotion. Look at the picture. The man, or I say men, we say men, okay? The man one, the red color, he is, what's that? The practitioner and for the making of value. If in public health, maybe penyuluh kesehatan or petugas promosi, yeah. So he have a good concept, and then he must send the knowledge to 1 or 2 person until they have good change behavior. For example, if we talk about smoking behavior, to stop smoking behavior, I have good program, and then I choose 1 person who's smoking. I try to teach them. I give education about how to stop with that smoking until he can stop. And then for this man, we call maybe with that Ronnie. Okay, Ronnie must find someone or must find another one who has the same cases, that is a smoker, and then do health promotion, and then give the quality of life about don't smoke is very nice life, for example, and to continue. It is more effective because the environmental support is very good. Okay, next slide, please. Okay, ladies and gentlemen, I have the application, how to apply the health promotion or multi-level health promotion. For example, in the program early detection of breast cancer, some of midwifery, for example, the practitioner of midwifery, I called maybe Miss Sandy. Miss Sandy is midwifery, has good concept about early detection of breast cancer. She have good knowledge. She has good concept. And then Miss Santi finds someone, of course, some girl. For example, Miss Santi find Nursiani, Miss Nursiani. Miss Santi teach or give the education about early detection of breast cancer to Miss Nursiani until Miss Nursiani have good enough. And then Miss Nursiani, after do early diagnosis of breast cancer with good, find someone. We call, for example, Salva Ayu. Nursiani teach Salva Ayu and each other. Salva Ayu teach Hesti teach Fernanda teach and each other. It is the application of multi-level health promotion. Okay, next. For the second application for prevention of smoking, it's the same. This is just example. For the preventing of smoking, as also when I find someone, as we know, for the last time, for many years ago, I'm a smoker. But for a long time, I'm not smoke, and I can stop smoke. I have the theory or the trick how can stop smoke. I teach each other. For example, I teach Fernando, I teach Fatur, I teach Sahari, I teach each other, and continue. Okay, for next application. For this application, for example, promotion of sport, it's the same. It's the same with breast cancer and also stop smoking, promotion sport in each other. For the next, healthy living, of course, how to apply to our life with the healthy living. Yeah. So we have a good lifestyle. Continue. Okay, ladies and gentlemen, this is for the illustration, for the last illustration for me. Yeah, for me, that's multi-level health promotion. I think this is my mind. It is very important to apply in health sector. Not only in health promotion, but also in nutrition, in epidemiology, in environmental health, in safety health, or in management, or in nursing, midwifery, pharmacy, radiology, and each other. Okay, I think that it is very confirmed with the many department or concerned in health. Continue. Okay, ladies and gentlemen, for the conclusion, multi-level health promotion is very, very important, I think. So the competence of individual actors will be increased. The opportunities provided by health promotion policies are significant predictor the participation in health promotion action. With the multi-level health promotion, it can also increase the health promotion value on such action. The next conclusion. Moreover, people's perception of their own political efficacy, their influence on community decision that affect their health turns out to be significant predictor. So, ladies and gentlemen, with multi-level health promotion framework, I'm sure we can more effectiveness of health promoting policy. Okay, ladies and gentlemen, that's all my presentation. If you have any question, we can make of with that discussion. I take so many reference like Bandura and each other, and I say thank you very much. And don't forget, we can discuss more and more about multi-level health promotion. Thank you very much, Ms. Sandu.
Okay, thank you very much, Mr. Ali Sodik, for your very interesting information. And now we come to the last session, question and answer session. And now we have some questions already we collect from the participants. Question from the first speaker, Mr. Zainal. You have some question here. I will read. The new COVID-19 cases were very high in July, but it can manage very fast, and the daily new cases nowadays is quite low. Why this phenomena occurs? And the second, regarding the reduction of the PPKM level in Madiun City to level 1, what about the implementation of health protocols by the community? Okay, maybe Mr. Zainal, you can answer directly. Hello, Mr. Zainal, are you there?
Yes, thank you.
Okay,
please. Okay. This 3 question, and then thank you for question. Yes, I can be said to have success in suppressing the number of incidents where starting in July with the PPKM, that restriction on community activities where the community and can be said to be this at maintaining health and maintaining immunity. Likewise, with evidence that the public always come to be present of vaccination or where maintain distance and maintain immunity with nutrition food, sufficient vitamin. So the health protocol is, I said that this is the main key. Now with road closed, no one gate system. Itu jawaban yang dapat saya sampaikan dari 3 pertanyaan menjadi satu bagian, bahwasanya disiplin terhadap protokol kesehatan itu sangat penting bagi kita semua untuk dapat mencegah penularan yang terjadi. Saya kira itu. Thank you.
Thank you for your answer, Mr. Jainal. And we go to the next question for Mrs. Nurwijayanti. Do you have some question too? I will read. The COVID-19 pandemic has occurred for almost 2 years. Indirectly, this will have an impact on the nutritional status of children and toddlers. What steps can we take to improve potential human resources in the future who are currently affected by COVID-19? And the second question, providing organic food is a safe way to increase nutrition for everyone, but the problem is organic food is much more expensive. Do you have any suggestion for this problem? And next question, we all know that this pandemic is affecting everything, especially the economy. What I want to ask, what do you think is the nutritional status in the current pandemic era when viewed from an economic perspective, especially in fulfilling nutrition for families? Please be answered, Dr. Nurwijayanti.
Yes, okay, thank you for the question. I try answer the first about the nutrition in era pandemic COVID-19. Nutrition status is affected by several factors, which is food intake and infectious disease. In pandemic era, food intake is amount to repair the nutrition status because many people, stay at home, especially the mother that have the responsibility to take care of the children, including their intake food. Also, they need to pay more attention to the hygiene that can lower the possibility to get the infectious disease. Thus, the parents need to give their children a balanced nutrition food that can help them to boost the immune system, so it will lower the chance to get infectious by the coronavirus. Besides, on discuss data 2020, the nutrition status with wasting is lower than here before. So it means the parents' success have to retire the nutrition status. And then the second question, inorganic or organic or inorganic. Organic or inorganic food is actually the same. It depends to how we cook the food, how we try to keep the food clean and pay attention to hygiene and so on. It is included in food security. And then how to try to keep the food is very interesting because the nutrition in the food is how to try to keep. And then the biggest health issue in stunting, yeah. Okay, and then stunting among the direct factor of malnutrition in inappropriate feeding partners, below the nutrition adequate rates resulting in low energy and protein intake. In addition, the presence of infectious disease may cause children under 5 to lose the appetite, result in the reduced intake of food and drink in their body. Infectious among the leading cases of infant mortality in Indonesia. And then I think the question among factor malnutrition is the intake and infectious disease is very interesting. And then the question and forget, and then sorry, chat. Okay. And then the support growth, the growth and development of children is necessary to meet the nutrition need of the children, macro and micronutrient. Yeah, choosing the right food to prevent children from experience malnutrition or even malnutrition in environment, health, hygiene, and health sanitation is very interesting now. And then in era pandemi is the environment, hygiene, and health sanitation is very interesting for support a growth the child under 5 years. And then back to moderator.
Thank you, Bu Nurwijayanti, for your answer. And we go to next question for Mr. Ali Sojek. 3 questions. First, multi-level health promotion requires involvement from many sectors, such as environment, competence, action, and others. In your opinion, which sector is the easiest to reach first to determine priority steps for solving health problems? And the second, a lot of time is required to change behavior. what is the fastest intervention for behavior change? And the third, how are special tips to increase promotion, especially in terms of health? Because in this pandemic period, many are less interested in becoming health workers, as a case study like what happened in Singapore, where many medical personnel have resigned. Please, your answer.
Okay, thank you very much, Ms. Santi. Ladies and gentlemen, from this question, it is very interesting question. For the first question about was that the requires from many sector. I think that like this. When we have good value about something, for example, and then this is has become policy. We only have need was that capacity or competence. Okay, I think that for about competence is all of hard worker. Yeah, was that the old friend or nursing or midwifery or health promoter? They have good quality, good competence. Just need action. Need action. I think that not to give with that health education is not only in with that in the meeting, but also we can do one by one, and then for someone have give with that the health education will teach each other. When in with that in Javanese style, kalau dalam bahasa Jawa, Javanese style, we know ketok tular. Ketok tular. Okay, so I have good with that idea or good value, so I give to other one, the other one give to other one gains, and to other and each other. So to solving this problem, I think all of priority. We can start to competence, and then action, and then environment. Environment that mean is someone who want to give this value to other one. It is for the first question. For the second question, it is very interesting to change behavior. Yes, as we know, we need many with it many times. Okay, can faster. But because of today, I present the multi-level health promotion. I'm sure that multi-level health promotion can become one of solution, one of model, one of way to change behavior as fast as possible. Then penyuluhan or each other. Then we use media. Was that banner on each other? I think that multi-level health promotion is very was that confirmed with this situation. This is as the same to question for next question. What the mass was that do in pandemic era? For multi-level health promotion, we can do not only face-to-face, but also we can do with mobile. For example, I want to try to give explanation about health with that cancer breastfeeding detection. I can call someone who I know and interesting. After that, the someone can phone each other. So I think it is can increase for the medical personnel with that hard work in the hospital and each other. So if we it's only the only medical personnel works by themselves, it is very hard. So environmental such as the someone who interesting in health, we can do and we can support for this to increase for this pandemic. Thank you very much, Santi.
Okay, thank you very much, Mr. Ali Sodik, for your answers. Ladies and gentlemen, we still have many questions here, but unfortunately, we must close the third session. But the question from all participants, we will share to the speakers to be answered in the next occasion. Okay. Before we close this session, we will give the certificate to all speakers in the third session. Please show the certificate. And the first certificate is given to Mr. Zainal Abidin from Stikes Bakti Husada Mulia Madiun. And the second is given to Dr. Nurwijayanti MKes from IIK Strada Indonesia. And the third is given to Mr. Ali Sodik from IIK Strada Indonesia. I'd like to thank you so much to the speaker for informative performance and to all the participants very active here. Hopefully the topic will be beneficial for everybody. Amen.
Amen.
Then we have to close the third session and we will back to the Master of Ceremony. Thank you very much.
Well, okay, thank you very much for the amazing speaker for especially our co-host from Strada, Bakti Husada and I'm joined chairwoman and co-chairwoman. So this is our first day of Strada International Conference on Health 2021. Thank you for the participation for today.
Ladies and gentlemen, thank you for your participation. We really apologize if you find something error in our international conference. And we are really pleased to invite you for the speaker for tomorrow for the oral presentation on the third Strada International Conference on Health 2021. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.